This is Dr. Sharmila Sengupta, along with Dr. Pooja Sharma, the Director of Medanta Institute of Education and Research, and Dr. Sanjeev Singh, Director Amrita Institute of Medical Sciences, as the co-hosting of the workshop. We welcome all the participants from Nepal, Bangladesh, Philippines, Singapore, and India to the 4th day of the 5-day bonanza of interactive learning on implementation of antibiotic stewardship, antimicrobial stewardship in resource-limited settings. The workshop is structured to cause minimal disturbance in your daily work, yet give you daily food for thought. The sessions are structured for 2.5 hours a day from 4 to 6:30 Indian Standard Time, with a highly knowledgeable and expert international faculty speaking for 2 of those hours, followed by a half-hour interaction with the participants, provided they don't shoot the time, of course. Some of our speakers are presenting live today, and some are pre-recorded sessions. So I would request all the speakers to keep to their 20 minutes time zone. And there will be a team member who will remind you after 18 minutes with a small buzzer. You are requested to put up all queries, comments, or discussion on the chat box, and the moderator of the day's event will ensure that you are your questions have been taken care of. We also request you to fill up a daily feedback form from that, which will be put up on the chat box. That is, if you have not done it already. For today's session, the theme is challenges to opportunities, and we will be presenting the situations from all the 4 countries who are participating. My moderator today is Dr. Anita Arora, who is not only a good friend, but I can say that Dr. Anita Arora started working in infection prevention and control much before it even became known to many people in India. She's currently the Director of Medical Operations and in National Capital Region of Delhi, and also of the Group Head for Kolkata Infection, and she's also the Group Head for Infection Control in Fortis Group of Hospitals. She has been a Share Ambassador in the 2010 conference, and also a Principal Assessor of NABH and a past member of the NABH Technical Committee. She has done her fellowship on Global Training Program in Occupational Exposure and Prevention from the University of Virginia, and has a good number of national and international publications. She has also contributed to the Infection Prevention National Guidelines and is author of chapters of books on infection prevention and control. We welcome you, Dr. Anita. You take over the session from now on.
Thank you so much, Sharmila, and good afternoon, good evening to all of you. Thank you so much for that kind introduction, Sharmila, and I welcome all our speakers who've joined and the participants. The process will be that I will first introduce the speakers for each session. Sometimes there are 2 in each session of 20 minutes. And then the speakers will either share, either there will be a pre-recorded presentation or the speakers will share their presentation live. So let me begin by first sharing about our first 2 speakers. So our first speaker of those 2 speakers for the first session, which is from Bangladesh, will be The first one is Mohammed Golam Dostogir Harun. I hope I've pronounced it correctly. He's currently Deputy Project Coordinator at the International Center for Diarrheal Disease Research and also Assistant Professor part-time at the Department of Public Health at Daffodil International University, based at Bangladesh. He's a social graduate from Dhaka University and has completed his master's degree in Women and Gender Study from Dhaka University and an MPH in Epidemiology from the same university and Daffodil International University. He's also completed postgraduate courses on international health from the Johns Hopkins Bloomberg School of Public Health. He has worked as a public specialist for the past 15 years and has experience and expertise in infection prevention and control, antimicrobial resistance, various trials about water sanitation and hygiene, capacity building, training and development, and a whole lot of other things. He is a member of different national and international infection control alliances and contributes to infection control in hospital settings. He recently contributed to developing the Bangladesh National Infection Control Guideline for hospital settings and the COVID-19 infection control and management. He has various national and international publications, and he has attended various national and international conferences to present his study findings related to public health and to other aspects. Welcome, Mohammed Golam Dostogir Harun. I think I got muted, I'm sorry. I would also at this point like to introduce our second speaker too of this session on Bangladesh, Dr. Tahmidul Haque. He's an aspiring public health professional with extensive formal knowledge and training in clinical science and health education. He has served a number of public, private, and international agencies, including tertiary care hospitals and global health organizations, and played a significant role in small and larger groups. He's an MBBS from Sir Salimullah Medical College, and later he's done his WHO TDR, that's Tropical Disease Research Fellowship on Implement Research in 2020, and completed his MPH from BRAC, James P. Grant School of Public Health. He is serving currently as a research fellow at the Program for Emerging Infections, Infectious Diseases Division. And he has some papers under development and review, which have not been published yet. Welcome, Dr. Haque. And now over to you both for your sessions. Nikita, at times, will, if you require, will pitch in to help you if there is a challenge in your presentation, whether recorded or live. So over to you, Dostogir Harun. You may start your presentation now. Hello? Is there...
Nikita, can you unmute Mr. Dostogir's connection? He has not been able to unmute himself.
Thank you. Thank you very much. Can you hear?
Yes, we can hear you.
Okay, thank you so much. So I would like to start a good news. Today is the Bangladesh Independent Days, and it's a great opportunity to be such a resourceful group and in such an important workshop. Sharmila, especially thanks for you for inviting and give me the opportunity for learning. Actually, last couple of days I'm learning a lot, and it's really, I had a lot of space to learn about this area, this very important area. So thank you. This good afternoon and good evening to everyone, and welcome to you all to my presentations, Challenges to Opportunities for the Implementation of Antimicrobial Stewardship Program in Bangladesh. So I'm going to tell a little bit about the background, especially the Bangladeshi background and AMR situations. I'm going to talk about my project, IPC and ASP initiatives, and I will focus mainly on the ASP scenario. And then I will share some study findings and what are the actually key challenges and prospects we found to implement ASP program in Bangladesh.
Mr. Dostogir, have you started your presentation? Because it's not visible.
Yes, I have started.
It is not shared here.
Oh, sorry. let me share. Sorry.
No problem.
Yeah. Can you see now?
Yes, we can. You could put it. Yes, it's on slideshow now. Yeah.
Okay.
Sure. Go ahead.
Okay. So I'm not going to tell about the background of the global because all the people have so much experience, but that's I'm going to highlight. Due to AMR, another 20 million people will be forced to live in extreme poverty. That's really challenging for developing countries beside the death and life toll. So underlying factors for the South Asian countries are almost similar, like easy access to all kinds of antibiotics that I learned from a couple of days. Speakers, irrational use of antibiotics, suboptimal hygiene condition for infection prevention control practice, and lack of and functional IPC and AMR surveillance. And in many countries, especially in Bangladesh, do not have the Antimicrobial Stewardship program. So these are the causes for ASP, antimicrobial, like AMR in developing or low resource setting like Bangladesh. So the Bangladesh scenario, if I just focus on the Bangladeshi scenario, actually antimicrobial resistant AMR is one of the major health threats right now in Bangladesh. And one study actually we conducted identified 56% of the people, Bangladeshi people, especially in urban area, Dhaka city, are resistant to at least one or more forms of antibiotics. Not only the hospital people, this includes the community people as well, like the healthy, it looks very healthy community people, and we found that. Another study identified that among the pneumonia affected under 5 hospitalized children, 40% of the secondary bacterial infections are resistant to multiple antibiotics. But the good thing, Bangladesh have high level political commitment and has been expressed by the government, like the highest level of government, to reduce the AMR burden. So if you see some, like the AMR resistant pattern of some like broadly used antibiotic in Bangladesh is really very alarming. And this surveillance was done by the Director General Health Services under the, the epidemiology and research control wings. So it's most of the widely antibiotics from that study got almost 90% resistance. So it's very, very concerning for Bangladesh. And if we see the susceptibility of antibiotics is like the 4th generation of antibiotic, or like this kind of antibiotic have the susceptibility. So this surveillance is also conducted by the similar corporate authorities. So we started actually IPC and ASP implementation studies, and we conducted this study in collaboration with Director General Health Services and US CDC since 2020 September. And our objective is to strengthen the infection prevention control measures and antimicrobial stewardship program in selected tertiary care hospital in Bangladesh. And we have started this initiative in 8 tertiary care hospitals across the countries, and 6 of them are public and 2 are private, but not very posh, like it's moderate private hospital, not fancy, not very poor, it's the moderate. And we wanted to explore the causes of antibiotic, or like the challenges and difficulties to establish the antimicrobial stewardship in Bangladesh. And we used the mixed method approach. We did physician antibiotic prescription survey quantitative survey, and we also did the in-depth interview and focus group discussion to explore the antibiotic use, pattern, perception, and key challenges to implement the antimicrobial stewardship program. So our study findings, some of the results you see, it still is going on. So we found that from the physician survey, we found they think the causes of antibiotics, 77% physician thinks easy access to antibiotics without prescription was found the most severe causes for AMR in Bangladesh. In Bangladesh, anyone can go anywhere and can buy any type of antibiotic, even without any prescriptions. So overprescription of broad spectrum antibiotic was opined by the 65% physician, and 42% thought that inadequate diagnostic lab test is also responsible for the overuse of antibiotic and like the AMR. And patient demand and expectation for receiving antibiotic is gradually actually increasing. And this is the tradition also responsible for 41% physician thought for the AMR increase in Bangladesh. And 21% physician blame for the poor infection control practice by the healthcare professional is increasing the infection rate and use inefficiently of antibiotics. So we also asked the physician approach of physician prescribing antibiotics, how they prescribe and where they learned. And they told that like the 68% physician routinely step down from IV antibiotics to oral as soon as possible. That was their opinion. And 42% physician told they consider the patient affordable capacity and their choice to prescribe antibiotics. And if sometimes they could not able to prescribe the antibiotic that's required because of patient choice or like the affordability. And routinely choose of spectrum antibiotics empirically as the most patients are infected with drug-resistant organism. That's found very commonly. And it is also difficult to get routinely microbiological report from the lab. And they like 29% physician thinks that result can guide us, but they don't get most of the time. So we ask about the physician about practice of like sending UTI culture and like how they deal the UTI cases, suspected UTI cases. And we found only 34% physicians sent urine for RME, and 28% physicians usually practice to send for both RME and CS before prescribing antibiotics, and sent for culture only like that 23% physicians, and rest of the physician actually prescribe antibiotic without this kind of things. And you see sent urine for urine culture only 11% physicians. Also, unfortunately, some physician, 2% physician thinks they are the qualified physician, MBBS physician, and they think they need not go for any test. They just give the antibiotics. This is the very practical scenario in Bangladesh. We also did the qualitative assessment, and we also found some issues related to antibiotic resistance. So if I go through some quoted from the junior physician and senior physician, you will see when we saw our senior doctors prescribing antibiotics and getting expected result, it increased our self-confidence, and we also tried to practice similarly. And also another physician told we have started from our word management books from Davidson or Oxford, but in Bangladesh, when we go for practice, we see the antibiotic strains are completely different. We also do not have got any formal training or any antibiotic use guideline. That's why we follow the senior doctor and prescribe accordingly, or we judge and give as per our assessment. Another physician told like it takes usually 3 days to get the culture and sensitivity result. The patient cannot, condition might be deteriorate by then. So we have start broad spectrum antibiotic without prescription. Another physician also told it would have been great to go for the CS, but do we have the facility to go for the culture test, please? Can all patients afford the cost and wait for the time? Also, many patients started antibiotics before coming to the hospitals. And the first physician told we might prescribe more antibiotics compared with developed countries. But considering our hospital ITC situation, how can a physician take risk not to give antibiotic considering the hospital hygiene situation and patient hygienic behaviors? So all these told, actually, this is the physicians think how they are going to give a lot of antibiotics to patients without prescription, or like why they're not giving less antibiotics. So we found from the qualitative and quantitative aspect, we found few factors that's constraint for implementing ASP in Bangladesh. One, like the number is facility associated. Bangladesh hospitals are highly populated. It's too much crowd. It's very difficult to maintain the infection prevention control or like the ASP programs in such. Lack of laboratory test enimities is also really difficult situation in Bangladesh, and lack of establishment of ASP in any hospitals. And Bangladeshi hospital, any hospital do not have any ASP program. Capacity associated factors to ASP program is lack of antibiotic use guideline at national level or hospital level, evidence-based practice among junior physicians, right? And lack of hands-on training for the IPC and ASP in healthcare facilities, including the junior physician to senior leadership position in hospitals. And drug compliance associated factors is irrational use drug prescribing by unqualified doctors. 67% of the antibiotic is sold in Bangladesh from the informal sectors, like the unqualified quack doctors or from the drug stores. Dispensing of antibiotic without prescription is a very common practice, and anyone can go and collect. An incomplete dose and duration of antibiotics. This also found another causes for drug treatment. And drastic promotion of antibiotics by the pharmaceutical companies. This is also increasing the use of antibiotic irrationally. So we actually finalized what are the key challenges if we wanted to implement the pilot the ASP program in Bangladesh. And from our studies, we found poor infection prevention control is the hindrance to implement successful ASP program. And lack of hospital specific antibiogram and antibiotic use guidelines. They told what guideline or what we have so that the physician will follow that guideline or prescribe accordingly. And prior intakes of antibiotics by most of the patients who deals, because we are implementing that ASP program in tertiary care hospital, and the patient referred from village or sub-district level hospital, and most got the antibiotic previously. And easy access to antibiotics is another reason for difficulties area for implementing ASP program, and lack of culture sensitivity test practice tradition, delay in test result, and lack of inadequate test facilities. Some government policies also like deteriorate the use of antibiotic or AMR issues in Bangladesh. Government hospital gives free antibiotics for 3 days only. So if the dose is for 7 days, then the patient are asked to come after 3 days to hospital. But usually patients do not come. If they are good, then they don't take, and most of the, like 90% of the patients do not come back for the rest 3 days course of the antibiotic. And actually lack of monitoring for compliance of antibiotic use from hospital top level to bottom level. So for the final conclusion and recommendation, hospital-specific antibiogram and antibiotic use line guideline is very much essential. ASP should be implemented through regular training to hospital leadership and with regular monitoring from the third party or diseases of high level. Functional AMR surveillance is crucial for the ASP program. Then they can get the result regularly and prepare the antibiogram based on the surveillance report. And easy access to antibiotic must be restricted through strict policy enforcement. Otherwise, it will be very difficult to implement the ASP program. And hospitals should be allocated with sufficient resource to conduct CS tests. So that was my very brief presentation, and this study is still going on, and we are hoping to get the final result in 3 months. So hopefully we'll be able to share the result in future as well. Thank you very much. And my colleagues, Dr. Tahmidul Haque is going to present the rest of the part of this presentation from the practical point of view.
Thank you, Dr. Dostogir. Thank you, Mr. Dostogir. And yes, we'll now listen to Dr. Haque. And please do stay on for Q&A, which will be at the end of this session. Thank you.
Thank you.
Thanks, Dr. Anita. Can you hear me, Dr. Anita?
Yes, you're audible.
Hello?
Yes,
Oh, yeah.
yes.
Ma'am, I already sent you my pre-recorded presentation
Right.
to be tied on time. So I think you can broadcast that one. Yeah, that will be including only 10 minutes. Yep.
Right. So Nikita.
Yes, I did share it, ma'am.
Nikita will put it up, and you can, let her know when you want to move the slides, Dr. Haque. Right?
Yeah. The total presentation is recorded there, so
okay.
I don't have to give any instruction. Thanks, ma'am.
Okay, that's good. Nikita, is there some challenge?
No, ma'am, I'm just sharing. Give me a second.
Sure.
Hello, this is Dr. Tahmidul Haque. I am currently working as a research fellow at the Program for Emerging Infections under Infectious Diseases Division at the International Center for Diarrheal Disease Research in Bangladesh, also shortly known as icddr. First of all, I would like to acknowledge my utmost gratitude towards the authorities who are organizing this global event at the podium of Medanta Institute of Education and Research. And today our topic is the challenges to opportunities for implementing antimicrobial stewardship program in Bangladesh and similar other resource constrained settings. So before we run into our presentation, I obviously would like to give you a hint that it would be more of a pictorial presentation. My previous presenter, Mr. Golam Dostogir Harun, already has opined his remarks regarding the overall scenario of AMR in context of Bangladesh. So these are more of a repetitive data that's stating that AMR is already one of the major health threats in Bangladesh. And also the studies have found that 56% people of Bangladesh, especially in Dhaka city, already are resistant to at least one or more forms of antibiotics. icddr during the tenure of 2014 to 17 conducted a study among the under 5 hospitalized children who were already going through pneumonia, and they found that 40% of the secondary bacterial infections were resistant to multiple forms of antibiotics. And our Honorable Prime Minister Sheikh Hasina has expressed her high-level political commitment to work along with the global leaders and form a common frontier in order to reduce the AMR burden, at least in Bangladesh context and also to the context of South Asia and the whole world. So what are the practical factors that are inhibiting the implementation of antimicrobial stewardship program in resource-constrained tertiary healthcare settings of Bangladesh? So let's just have a glance. So literatures have found that, and also we in the practical setting have found that most of the tertiary care hospitals are densely populated because they have got a policy of saying yes to every single patient. They cannot say no to any of the patients, and this is why it's inhibiting the optimal healthcare services and also the implementation of IPC measures. How? So if we have a look at these pictures, we can see that outdoor patients are waiting in long queue in a public hospital. The number of doctors and nurses are very small in comparison to the influx of patients. As a result, the staff-patient ratio can be hardly maintained, and indoors are already overloaded and flooded with patients and attendants in public hospitals. So whenever there will be a discrepancy in between the number of patients and the number of healthcare providers, there obviously would be some sort of dismantle in the implementation of IPC measures, because the optimum services cannot be provided and the optimum hygiene or sanitation cannot be maintained, which is also getting reflected in the next slide. We can see that most of the patient wash basins are non-functional and they are lacking soap supply. Even they are not having any other kind of hand washing reagents. Hand hygiene also is not getting adequately maintained while food or medicine are being distributed. If we have a quick look at the right bottom picture, we can see that there are many waste bins right there. They're getting flooded and overloaded, but unfortunately the color codes are not being properly maintained, and most of the waste bins are also not having the lids, although the international prescription says that they must be covered with lids. So suboptimal maintenance of this hand hygiene, sanitation and waste segregation ultimately is giving rise to the cross transmission of microbes, and these microbes are ultimately growing in an abundant manner, which is ultimately giving rise to the growth of also superbugs, which is ultimately getting into a big threat for Bangladesh. Also, we have found that routinely used antibiotics are being prescribed without any kind of culture sensitivity test or any other kind of diagnostic test that should be right there in the place according to the indication. But both in the admission order and post-operative order, these antibiotics are being prescribed without any kind of test. So ultimately, the bacteria that are living in our normal flora, for example, in our skin, in our mucous membrane, or like any other parts of our body, they're getting frequently, or we should say chronically exposed to these routinely used broad generation of antibiotics and are getting resistant. So ultimately, they are also getting resistant to common infectious diseases and ultimately giving rise to the growth of superbug, which is obviously a very alarming threat for our country. Patients are also coming from distant areas to the tertiary medical college hospitals, and we have found from the physicians to qualitative interview that patients usually ask them to prescribe antibiotics from a false perception that if they go through antibiotics, they would get a quick recovery. So ultimately, the physicians are getting bullied, or they're getting pressurized, or they're getting feared from the back of patients that they obviously have to provide antibiotics. Also, public hospitals are providing maximum 3 doses of free medications to the outdoor patients. If we have a quick look at the bottom picture, we can see that there is a medication center at a large tertiary care hospital of Bangladesh, which is remaining emptied. Because of what? Because the public hospitals are providing 3 days of free medications, and later on, as patients are coming from the remote, distant, or far-flung areas, they're not finding it. I should say they're not finding it from a moral point of view to come back to buy the second doses of antibiotics free of charge, or get those second doses of antibiotics. So ultimately, it's giving rise to the incomplete dose and duration of antibiotic consumption, ultimately leading to antimicrobial resistance. Also, pharmaceutical companies in our country employ a lot of medical representatives throughout the tertiary medical college hospitals, and the main task of these medical representatives are to provide lucrative monetary benefits and other benefits to the physicians, like the registrars, the consultants, the assistant registrars, and other doctors working in the tertiary or secondary healthcare centers for prescribing their specific drug products. Even if there is no justified indication, ultimately the physicians are getting nitty and gritty. They are getting allured by the lucrative monetary benefits, and they're providing those specific antibiotics from these specific companies, even if there is no rational use justifications. Ultimately, it's giving rise to antimicrobial resistance. Now, if we have a look at the capacity of our culture and sensitivity and other diagnostic tests, we already have found that most of the tertiary care hospitals only can conduct a very few number of culture and sensitivity tests. Actually, from one of our findings, we have found that a tertiary care hospital can conduct only about 10 to 15% of the total culture and sensitivity tests required in context of the hospital, and the remaining burden is carried out by the private diagnostic centers. Again, these culture sensitivity tests require at least 3 days time for the result to come out. So physicians obviously cannot wait for that duration of time, because the patient's condition obviously might get worse. So in fear of that, they start providing broad spectrum antibiotics in advance. And also, patients who are coming from the lower socioeconomic status, they cannot go through such sort of expensive culture tests, the private diagnostic centers, where these tests are conducted most of the times. So ultimately, there is no specific proof of or indication of infection being grown, but still, from their knowledge and experience, physicians are providing these antibiotics totally irrationally, or I should say undisputedly, which is giving rise to antimicrobial resistance. So in lieu of this, based on these underlying factors, Bangladesh government has taken some initiatives recently. For example, the 6 years National Strategic Action Plan has been introduced to ensure the antimicrobial resistance containment. Bangladesh is also providing regular data to WHO GLASS project. Those who don't know, I should acknowledge with them with the fact that WHO GLASS is a regional AMR surveillance project that has been running since 2014 for establishing a regional specific functional AMR surveillance. DGDA, also known as Director General of Drug Administration, which is the drug controlling authority of our country, they have issued special order to restrict the dispensing of antibiotics without any kind of prescription. Unfortunately, we are having this mushrooming of pharmacies, and most of the pharmacies are not under the watch control of DGDA, which is obviously a very heinous factor. But we think that the situation will be changing in course of time. Regular media campaigns are also being organized by the media cell of our government to raise mass awareness against the antimicrobial resistance. So finally, we have come up with some recommendations from our project and from our insights and experiences that national level policies should be properly implemented from grassroots to central level drastically to combat AMR, and regular training sessions on antimicrobial stewardship program should be organized at all the hospitals with proper monitoring compliance, and standard infection prevention control practices should be maintained in the hospital settings. So here goes my presentation. Thank you very much, everyone. I have already provided my email address and WhatsApp number to the organizing committee. Those who want to also share their personal opinions, shares views or experiences with me, please do keep in touch. Stay tuned with us. And obviously, if we work together and if we can go through this proper ASP implementation and IPC measure proper initiative implementation, we can obviously hope for a better future. Thank you, everyone.
Thank you, Dr. Haque. And so thank you, Bangladesh team, for Mr. Dostogir and Dr. Haque for, highlighting the challenges you face in Bangladesh and how the government and as well as you have been trying to, do their best. Of course, you will continue to do as much as you can and push this agenda. I wish you all the best in that. And please do stay on for the question and answer session at the end of this session. With that, I would like to now introduce the next speakers who are from the Philippines. So we have Joyce, who is Joyce is probably a a more commonly used name. She's probably called Jocelyn Socao-Alumno, and I didn't know that she's Joyce. Is Jocelyn. Just today, I think Joyce, I've got to know that. So I'd just like to introduce Joyce, who's a lovely friend I've got to know over the years. We got together again recently. I had met her many years ago, probably 10 years ago, and then we recently connected. I would like to introduce her to you all. She's a staunch advocate of healthcare globalization and medical tourism. She has led various initiatives in the Philippines and internationally by partnering with the government and private sectors in the development and promotion of the country as a global healthcare destination and in the capability and capacity building of the country's healthcare organizations towards global competitiveness since 2004. In recent years, she's been advocating the ASEAN economic community integration for healthcare trade services and promoting international standards in healthcare and hospitality towards patient safety and excellent quality healthcare. She is the founder and president of HealthCore, the Center for Global Healthcare Management, Quality Accreditation and Medical Tourism Services in the Philippines, conducts and facilitates workshops and conferences on international healthcare management that includes compliance to the accreditation standards of the Joint Commission International, TEMOS, Accreditation Canada, Swiss Approval, ISO, among others, and even NABH International. In 2019, she spearheaded the creation of Health, Retirement and Tourism, HEART, Alliance of the Philippines, which is a private sector association that seeks to support the government in developing and promoting the Philippines as a global health tourism and retirement destination, where she was eventually elected founding president. In 2020, she became the Patient Safety Ambassador ASEAN region of the Patient Safety Movement Foundation based in the US. Welcome, Joyce. And now let me introduce our other speaker too for the Philippines session, Dr. Karl Henson. He is the Chair, Antimicrobial Stewardship Committee and Director, Hospital Infection Control and Epidemiology, the Medical City in the Philippines. He is Training Officer, Program Director for the Infectious Disease Fellowship Program at the same place, Clinical Associate Professor, Division of Infectious Disease for the University of Philippines, Manila College of Medicine, Board Member, Philippine Society for Microbiology and Infectious Diseases, and a Fellow, Philippine College of Physicians, Philippine Society for Microbiology and Infectious Diseases, and the Infectious Disease Society of America. Welcome, Dr. Henson, and welcome both of you. I would hand it over to you to talk about challenges to opportunities in Philippines. I guess Joyce will go first, and after that, you'll be Dr. Henson. So over to you. And Nikita, do please help wherever required.
Yeah. I think Joyce, I'm going first, right?
Yes.
Joyce is going first?
Yeah. Okay. I'm going first, yeah.
Oh, you're going first?
So okay, okay. So good evening, everyone. Thank you, Dr. Arora. Let me just share my screen. So thank you, first of all, to the organizers and to Joyce for the invitation to give this update on what we're doing in the Philippines in terms of antimicrobial stewardship. These are my disclosures. And I want to start off by just giving you a background on the national effort to combat antimicrobial resistance. The formal national effort against AMR really started in 2011 when the Philippines signed up with during the World Health Day of 2011 the country committed to the 6-point agenda to combat antimicrobial resistance. A couple of years later, in 2014, there was a national order creating the Interagency Committee on Antimicrobial Resistance. And this is a committee that's composed of the Department of Health, the Department of Agriculture, and several other ministries tasked to look into antimicrobial resistance and to combat or to fight it. By 2015, things were more formalized. The National Action Plan was released, and here, stewardship was one of the key interventions that was identified to optimize the use of antimicrobials. This was the very first time where the Philippines had a formal roadmap towards containing, controlling, and preventing resistance. The National Action Plan is a multi-sectoral engagement similar to the Interagency Committee on AMR. And this committee, this effort is spearheaded by the Department of Health as well as the Department of Agriculture, given that we need to look at both human as well as animal antimicrobial use. The National Action Plan had clear timelines, targets, responsible agencies, and a budget, as well as defined indicators for monitoring and evaluation. By 2016, the Philippine Action Plan was had some form, it was more formalized now in a manual of procedures for hospitals, and we started training the trainers. And by 2017, we started rolling it out into all the hospitals of the country, starting with the level 3 or the tertiary hospitals in 2017, and then level 2 in 2018, and then level 1 in 2019, with, of course, some interruption because of COVID-19. So what's in the National Action Plan? We don't really have time to go through it right now, but I wanted to just share with you the 2014 key indicators. We had 5 in 2014. The first one is to reduce nosocomial CRE infections by 30%. The second is to maintain at 0% the prevalence of ceftriaxone-resistant Neisseria gonorrhea. The third is to reduce by at least 30% the rate of MRSA bloodstream infections. The baseline data here is that year, 2014. The fourth is to reduce by 30% nosocomial infections with multi-drug resistant Pseudomonas. And the fifth is to reduce by 25% ciprofloxacin-resistant NTS or non-typhoidal Salmonella infections. We did this we started to roll out the AMS training by conducting workshops. We invited a physician, a pharmacist, a microbiologist, and a nurse to come to several training hubs located all over the country. And they underwent a 3 or 5 day workshop. And this was, again, all pre-COVID. The main content of those workshops really talked about the 6 core elements, basically on how to establish an antimicrobial stewardship program in their own hospitals. So they talked about leadership. They talked about the importance of guidelines and pathways, which is core element 2. They were taught, especially the clinical pharmacists, they were taught how to do surveillance of antimicrobial use and resistance. They were taught how to do interventions in terms of restrictions and audit and feedback, etc. How to do educational activities in their own hospitals. And then they were also taught how to monitor their performance and to evaluate their program. So what has happened since we started training? This is the most recent data that we have. As of this year, 99.12% of level 3 hospitals have been trained, have received training. 85% of level 2 hospitals and level 1 hospitals, about 40% or less than 40% have been trained, because this was right around the time where COVID hit and we had to stop with the training. But this has now resumed in an online format. So let's go back to the targets back in 2014 and see how we've been doing. The most recent data that I have is from 2017. So the baseline CRE rate was at 4.5%. The target is to bring it down to 3.1%. And in 2017, our rate was at 8.4%. So we're way off target in this regard. There is also an increase in the rates of nosocomial CREs, 11.2% in 2017. We maintained the 0% ceftriaxone-resistant Neisseria gonorrhea. The rate for MRSA bloodstream infections slightly decreased, but not yet to the target of 2020 of 42%. Pseudomonal infections also very slightly dropped to 20% from 21.6%. And then the ciprofloxacin-resistant NTS also dropped to 9% from 21.6%. So very mixed effects so far. And now, since we're already done with the first national action plan, there is actually a new action plan, 2019 to 2023, where we have similar targets. The first 5 are very similar, but this one has more modest goals at 10% reduction of nosocomial CRE and MRSA infections, as well as pseudomonal infections. But we added 2 additional targets: a 10% reduction in the use of antibiotics in both humans and animals, as well as we want to generate baseline antimicrobial resistance rates in the animal sector. So that is now the goal of the Department of Agriculture, to start generating data on animals. Now, this year, we were also given the report, the impact assessment of the implementation of the Antimicrobial Stewardship Program. And this really reveals a lot of the challenges as well as areas to work on in the National Antimicrobial Stewardship Program. This was done by a technical consultant of the WHO Philippine office, Carmela Barcelona. So this is the overview, the AMS core element report card. We talked about the 6 elements that we teach in the AMS workshops. We talked about leadership, policies, etc. So those core elements have specific items that need to be done in specific years. So for example, all level 3 hospitals must have an AMS team by 2018. All level 1 hospitals must have an AMS team by 2020. So just to sort of give you a preview, all hospitals, all level 3 hospitals must have restriction and pre-authorization efforts by 2018. All level 1 hospitals must have all those set up by 2020. So that's how we took a look at the performance of the hospitals when this impact assessment was created or was done. And you have on your right the results of the assessment. So for example, 88% of hospitals in level 3 hospitals already had an AMS team in place and an ICC committee in place. And the average here is about 85% nationwide. Some significant results here is in number 4, action. Very low numbers, 55% overall in the level 3 hospitals. These are tertiary hospitals. 61% of level 3 hospitals have all the 4 actions in place, and that includes restriction and pre-authorization, the 7th-day automatic stop order, point-of-care interventions, and audit and feedback. Now, when you take a look at the breakdown down here, where we're really lacking is the implementation of the audit and feedback. 36% of hospitals in level 3 hospitals were implementing as of this year, or as of 2020. So we need to do a lot of work in terms of getting the action part moving. This is another competency report card, and this tells us, so you have here on the very left, the various healthcare workers involved in antimicrobial stewardship This is a registered medical technician. This is a microbiologist, MD. RN is, of course, a nurse. RPH is a registered pharmacist, and doctors. So I just want to focus on, say, the clinical pharmacists or the RPH in terms of their knowledge about AMS. So B is basic, I is intermediate knowledge, A is advanced knowledge. No? So for registered pharmacists, for example, a good chunk of them in terms of knowledge about antimicrobial resistance, 49% identified as having intermediate knowledge, 27% as having advanced knowledge. And regarding antibiotics, again, it's more just intermediate knowledge. And for microbiology, just 58%. So the message in this report card really is we are able to identify which areas to strengthen in terms of training our healthcare workers, on what they need to know more in terms of antimicrobial stewardship. We also asked about what further trainings they need. And very obviously, you will see the word antibiogram as the largest, among all the words. This is a word cloud. That means that a lot of the respondents of that survey thought that they needed more information about how to construct an antibiogram. The other words here that you see, surveillance, observership, antibiotics, bacteriology, surgical prophylaxis, etc. But the biggest ones here really are, I think, relates to antibiogram and microbiology. And then I think this is my last slide on the report cards. We also took a look at the specific antimicrobial stewardship interventions. So we looked at the use of indications for antibiotic use, stop and review date, compliance with CPGs, etc. These are all the elements that we are looking for in each of the programs of the hospitals. No? And what you see here are the compliance rates from 2019 to 2020. There is some improvement in some of the elements, but I think that just taking a look at it, we're still seeing 35% compliance for level 3s, for example. So there we still have a lot of work to do. I want to spend my last few minutes talking about just the picture of a hospital, local implementation of AMS, and I want to show you the data of my own hospital. The Medical City is a tertiary level hospital. We are affiliated with a university, and it is a Joint Commission in International Accredited Institution. This is the setup of my center, Hospital Infection Control and Epidemiology Center, where I sit as director, but I concurrently sit as the Antimicrobial Stewardship Chair, and we directly report to the Chief Medical Officer. The AMS Committee is composed of myself as AMS Chair, and I work with a clinical pharmacist who is my supervisor, AMS specialist. We work with infectious disease consultants, the director of the microbiology section, the manager of the pharmacy department, as well as clinical pharmacists who do the day-to-day work. These are basically a summary of the various interventions that we employ. We have antimicrobial restriction and pre-authorization, automatic stop order, audit and feedback, and point of care interventions divided as persuasive and restrictive intervention strategies. Now, I want to focus on audit and feedback because, as you can see, the Philippines needs a lot of strengthening of the audit and feedback. And I will show you later that it has a very big impact in terms of antimicrobial use. So, for example, in 2020, the target for our hospital is 75% intervention acceptance, meaning out of all the interventions that we recommend, 75% should be accepted by the medical team. And we sort of hit that most of the time. This is our antibiotic consumption data in defined daily doses out of 1,000 patient days. And as you can see, after the start of the audit and feedback in June of 2018, we started to see a drop. in the consumption of this is ceftriaxone. And this even spans into the COVID-19 pandemic. Even through the COVID-19 pandemic, we were seeing low numbers of ceftriaxone intake. We had the same data for ceftriaxone, but when you take a look at piptazo, the piperacillin tazobactam became the workhorse of the hospital during the COVID-19 pandemic. There was overprescription because patients presented with pneumonia. But as you can see, if you take out the 2020 data, we were already seeing a downtrend in the consumption of piptazo. And that rise that you see up here really was only because of COVID. So we're hoping that once COVID is over, we will have a more realistic picture of how much of piptazo we use. In terms of restricted antimicrobials, so in Medical City and in a lot of hospitals in the Philippines, you are not able to prescribe carbapenems and the other broad spectrum antibiotics without the approval of infectious diseases or an antimicrobial stewardship trained doctor. So in up to 2019, we were seeing a drop in the use of meropenem and a slight rise in the use of ertapenem, likely because of avoiding pseudomonal coverage use. However, the numbers started to rise again by 2020, again because of the COVID-19 pandemic. So that's my data, and I always want to end my talk on stewardship by showing this diagram. And this emphasizes for all of us that antimicrobial stewardship really is a multidisciplinary activity. The physicians, the clinical pharmacists, the microbiologists, the nurses all need to work together in order to make the patient understand antibiotics, but also to keep him safe from antibiotic-resistant bugs. I would like to acknowledge Dr. Burba, Ms. Barcelona, and Kathy Rayos for the data in the slides. Thank you very much for your kind attention. I'm sure there will be time later on for some questions.
Thank you, Dr. Henson, for sharing both your national action plan and the progress on that front, as well as how you've done in your own hospital. Thank you so much. Now over to Joyce. Joyce, you would like your pre-recorded presentation to be shown?
Yes, hi, good evening, Dr. Anita. It was actually supposed to come ahead of Dr. Karl's presentation where I introduced him. Nonetheless, it should be okay. So if the pre-recorded message is ready, then you can just play it. But then before that, I would like to, of course, wish everybody a safe evening, especially our dear friends in Central Philippines in the Visayas region who are currently experiencing strong typhoon. So if the recorded presentation is ready, then you can just play it. And I'll be here for the Q&A later on. Dr.
Yeah, sure. I think Nikita is putting it up. Yeah.
Good day to all of you. And as we say it in the Philippines, mabuhay. Firstly, I'd like to thank Dr. Sharmila Sengupta, Dr. Sanjeev Singh, and Dr. Anita Arora for this kind invitation for including us, the Philippines, in this international gathering of experts on antimicrobial stewardship. Thank you so much. Also, my gratitude to them for being our mentors here in the Philippines, for doing several online workshops related to infection prevention and control and AMR. So today I was asked to talk briefly about the challenges that we experience here in the Philippines in relation to antimicrobial stewardship. And I believe that just like any other country, we have been facing several challenges in the implementation of antimicrobial stewardship program with the COVID-19 pandemic hitting the world. So for what is identified as a resource-limited country like the Philippines, I observe that we are still lacking so much in terms of generating awareness and conscious efforts to aggressively promote ASP. So on that note, let me quickly share with you what we have done so far since 2014 when our Department of Health set in motion the development of national plans, as well as the implementation of specific actions from increased vigilance against AMR. I'm going to share with you a few slides, and most of them are actually lifted from the report given to us by the Department of Health. And then later on, I will be followed by another colleague, an infectious disease specialist from one of the leading hospitals here in the Philippines. So just to give you a background, I'm Joyce Alumno, and I represent HealthCore Academy. And a bit of information for all of you regarding the Philippines. Just before COVID-19 hit us in 2020, it was in 2019 that the World Health Organization actually called the attention of our Minister of Health in our country, is saying that it's time to end tuberculosis in the Philippines. Why is that so? Because right now, there are still about 1 million Filipinos having or suffering from an active tuberculosis. In fact, we were said to have the third highest prevalence rate in the world after South Africa and Lesotho, with more than 70 deaths daily. And so it is within this context that our country has developed the Philippine National Action Plan to combat antimicrobial resistance through a One Health approach. And we started with developing the program in 2012, and we were able to launch the Philippine Action Plan to combat AMR in 2018, effectively in 2019. And as we all know, just a few months after we were hit by the COVID-19 virus. And I would also like to share with you a survey that we have conducted among Philippine hospitals during one of our workshops. And this was after COVID-19, of course, or during COVID-19 pandemic. And this was in January 27, 2021. I think Dr. Sharmila and Dr. Sanjeev were some of our faculty at the time. And we had 184 respondents from different healthcare providers or from different hospitals. And we conducted a survey as to how many of the facilities or these hospitals have a dedicated AMS team. And we gathered that still 23% of them do not have a dedicated AMS team. And another question or another survey was done as to whether their hospitals have a pharmacist that is responsible for leading implementation efforts to improve antibiotic use. And we learned that there are still 14% of them who do not have involvement or active involvement of the pharmacists in terms of implementing the antibiotic or improving antibiotic use. Again, another question was asked whether their facility are able to track antibiotic use, and 20% of them, or about, I'd say about 40 of them, are not able to track antibiotic use. One more question was asked whether their physicians or the doctors actually use written procedures in prescribing antibiotics, and we were just surprised that there are still very few who are not writing prescriptions in prescribing antibiotics. And so we learned that we still had several challenges, and these challenges, of course, are ways to improve and ways for us or opportunities for us to improve on. And these are some of the challenges that we recognize. One is that we need to maximize the One Health approach that we have been talking about by clearly defining the specific roles of the different stakeholders. We also need to strengthen the surveillance mechanisms and the monitoring of AMR data in our hospitals. Right now, there is no clear mandate as to how we are going to gather the AMR data and interpret them from the hospitals. We are working on having an online database for the AMR indicators. and this is not yet available. Another challenge is that although there is now a database of the antimicrobials for human use, this is not available in the veterinary sector. Again, we need surveillance within the agricultural sector, which is still not yet unified, with some private companies conducting their own surveillance activities. So we have not yet integrated the veterinary or the agricultural sector with the Department of Health's effort in gathering all this data. Another challenge, or I'd say opportunity for us, is for the regional laboratory capacity to detect AMR. And we need to build that both not just for human, but also for the animal sector. And we need to integrate the surveillance system for antimicrobial medicine consumption, the antimicrobial use, and hospital-acquired infection. All of this will still need to be developed as we realize. Another challenge is to harmonize the policies, the protocols, and the technical guidance for the different areas of the AMR work. We already have the ASEAN guidelines for the prudent use of antimicrobials, but this is yet to be adopted locally. Another challenge is that we need to strengthen our resources in order to meet the demands. We don't have much budget in order for us to really monitor and implement the AMR or the AMS or the ASP programs. We need the involvement of our local government units in order for them to allocate the funds. Likewise, another challenge is that we need to develop a national infection prevention and control program, not just in the hospitals, but also for backyard and industry farms. And so with that, there was an agency committee on AMR that was created in 2014. And this involved both our Ministry of Health and our Ministry of Agriculture, and with the involvement of our ministry or the Department of Trade and Industry, the local government units, as well as the Department of Science and Technology. These are some of our stakeholders. These are hospitals, of course, the academe. We have patient support groups, the media, and the public. And definitely we need to still strengthen the consolidation and consolidate the efforts of all these stakeholders. These are some of the key achievements from 2015 to 2017. So far, we have done some antimicrobial stewardship training and programs in our hospitals, as well as in primary healthcare settings. We have created national antibiotic guidelines, and our Department of Health has implemented the national policy on infection prevention and control in healthcare facilities since 2016. And from 2019 until 2023, these are some parts of the Philippine Action Plan. We are now aligned with the global and the regional agenda to combat AMR. We now have multi-sectoral engagement. We emphasize on One Health strategy, and there's now a joint resolution and adoption of the Philippine National Action Plan already signed by the principals of the ICOMR member agencies. And these are the key strategies that we are trying to implement since 2019 until 2023. Of course, with COVID-19 affecting us in 2020 and 2021, a lot of these efforts have taken a back seat, and now we're pushing for all of them to be placed on the forefront again in 2022 and 2023. These are some of the key strategies to commit to the National Action Plan through multi-sectoral engagement and accountability. Another strategy is to strengthen the surveillance and laboratory capacity, ensure uninterrupted access to safe and quality-assured antimicrobials, regulate and promote the rational use of antimicrobials, implement appropriate measures to reduce infection across all settings, promote innovation and research on AMR, and we're working with several agencies on the research and innovation globally, improve awareness and understanding of antimicrobial resistance through effective communication and education. I believe this is something that we need to strengthen in the coming years. And these are some of the blended learning programs that we have developed for our hospitals. We have asynchronous and synchronous sessions in educating our healthcare professionals. So these are some of the modules that are directed to the physicians, pharmacists, nurses, microbiologists, and technology. So these are some of the takeaway points. AMR, as we know, has been identified as a global health emergency even before and during the COVID-19 crisis, and still remains to be a formidable threat amid the pandemic. In all of this, the Philippines has been at the forefront of efforts to prevent and control AMR through the One Health approach in partnership with relevant sectors in the country, as well as in the ASEAN region, and of course with India here, and in other countries like the UK and Singapore and the United States. I hope we can all work together in this. And as we know, the COVID-19 pandemic still threatens to push back any gains that we have achieved so far in our fight against AMR. It shifted away our focus, it created disruptions, and we need to accelerate the use of the unnecessary use of antimicrobials. Likewise, stewardship programs must be integrated with the pandemic response to limit the harm of resistant infections in the current pandemic and prevent future harm. So on that note, I'll leave you with a quote that alone we can do so little, but together we can do so much. Let us win the war against AMR. Thank you.
Right. Thank you, Joyce, for your presentation, crisp and clear, and you explained so well everything that you're doing in the Philippines. Thank you once again, and apologies for that confusion, that you were supposed to go first and then Dr. Henson. I hope you will forgive us. Next, we have the team from Nepal. We have two speakers from Nepal. And the first speaker is Professor Dr. Subhash Prasad Acharya. He will be speaking on antibiotic stewardship, the Nepalese perspective. So let me introduce Professor Acharya. I hope you're there, Professor Acharya. Anyway, probably Dr. Acharya will join us later, but I will introduce him, and we have his pre-recorded presentation so we could hear it. So Professor Acharya is a professor in anesthesiology and critical care, Institute of Medicine, Tribhuvan University. He's a consultant intensivist and head of critical care medicine unit at TU Teaching Hospital. Visiting consultant, head of critical care medicine and infection prevention and control at the Grande International Hospital. Deputy Director, TU Teaching Hospital, Kathmandu in Nepal, and President of the Nepal Critical Care Development Foundation. He's General Secretary, Asia Pacific Association of the Critical Care Medicine. So Nikita, could we have Dr. Professor Acharya's presentation?
Namaste everyone, I am here online. Thank you, ma'am.
Okay, good. Right, thank you, welcome.
Thank you, ma'am. Please kindly go ahead with the recorded presentation. Thank you.
Yeah, Nikita, over to you.
Good morning and namaste. I would like to thank respected Mehta sir and the organizers for giving me this opportunity to talk about the antimicrobial stewardship, the Nepalese perspective. These are my conflict of interests, and I work for these organizations. As we all know, when penicillin was discovered, the same time it was known and explained by Sir Alexander Fleming that a time may come when most of the microbes will become resistant to antibiotics. And that is prevailing in Nepal also. You know, like there are so many literatures that are coming up with increasing resistance of MDR organisms in isolates from Nepal, and the prevalence of MDR and ESBL has gone up. And also we could see some publications regarding NDM8 and NDM1 from Nepal. So there are a lot of resistance, but the antibiotic pipeline is dry. There are no newer antibiotics. So talking about antimicrobial stewardship program in Nepal, it was started in Grande International Hospital from 2015. This is the only hospital where we have a antimicrobial stewardship program. And initially we formulated a process and the delivery of antibiotics made a booklet for the program and circulated to the hospital. And at this time, I would like to thank Dr. Andrew Toter, who was an ID specialist from University of Tufts, Boston, and he was here in Kathmandu for 1 year. And then at that time, we could get his help to start this program. I'd also like to thank our clinical pharmacist, Upasana, who has been working as the coordinator for ASP from 2015. And we initially created this system of categorizing antibiotic as restricted and non-restricted. And then later there were a few concerns from the patient family. They started seeing the document as restricted antibiotic and even raised the questions like why my patient is being given restricted drugs. So we changed that to the drugs, antibiotics, those requires approval, and antibiotics, those do not require approval. And we kept this, all the details of the program in the guide, which was kept in all the units. And in our system, what happens is the provider or the specialist doctors who orders the restricted antimicrobial drugs, they need to get the approval. So someone from the team, either the doctor, consultant, or the resident or the medical officer, need to call the antimicrobial stewardship phone number, discuss with the approval team member, and then regarding various things, and then approval will be given, which can be indefinite or basically most of the time it's time limited for initial 2 to 3 days awaiting cultures. And the approval time is done between 8 a.m. and 8 p.m. or 7 days a week. After 8 p.m. at night, if any patients requires restricted antibiotic, the pharmacy will supply the dose till the next morning, 1 or 2 doses maximum. And then by the next morning, the prescribing team should be taking approval for the antibiotics. And this is how our works, ASP works. Whenever there is an ordering person, they fill the form and send to the pharmacy, whereas at the same time, the ordering team will talk to the ASP approval team, and then the approval team will in fact notify the pharmacy, and the pharmacy notes that notification. This notification will be made by phone by the ASP team, ASP approval team, and the pharmacy registers it in a register, and then the pharmacy verifies the prescribed drug and the approved drug, its dose, frequency, and then they dispense from the pharmacy to the ward. The nurse on the ward receives the form and then checks that, and then there are 2 copies, and then the drug is given by the nurse to the patient. So this is how our form looks like, with the patient details and then the name of the antibiotic, and then certain mitigations and other aspects. So we also review the antibiotic stewardship. Over time, what we do, what are the drugs commonly, we review that. the approved drugs. We also review the culture data and clinical outcome. And then we also review other logistic aspects like the form, review of the specialist who is giving approval, the approval team. ASP also formulated these guidelines on surgical prophylaxis for our hospital. This is for the orthopedic surgery. And we also have mentioned, like created this short antimicrobial therapy for commonly occurring infections in the hospital and their duration. And common antibiotics, we have given this, like when we formulated this common drug for pneumonia. The other recommended components of ASP, like standardizing order sets, clinical pathways, antibiotic order form, de-escalation of therapy, reviewing the culture dose optimization, IV to oral dosing, we also perform that. And most of this thing is done by, these are done by clinical pharmacists. And what are the challenges that we are facing in Nepal in the antimicrobial stewardship program? The main challenge is the resistance from the specialist. As we all know, we clinicians have the biggest egos, and we do not want to let others people. We don't want to let other people tell what antibiotics to use. So I am a consultant. These are the common thing that we usually face from the beginning. And another thing that we face is, this is my patient. I want to do whatever I want to do. And we try to explain them, no, sir, this is the hospital's patient. This is our patient. And even at times we had to call the Antimicrobial Stewardship Committee has to call the consultant and say that this is a hospital program. This is not your patient. This is not your clinic or home. If it's your patient, the patient should be treated at your clinic or at your home, not in the hospital. At times we had to say that, so that those things go on. And sometimes the main problem is like, when it's institutional, it's okay, but sometimes the clinicians start taking this personal against the approval team members or other clinicians who are in the Antimicrobial Stewardship Committee. Another is the poor knowledge about the patient's clinical status. I can give you an example, like we get a consult for a nephrology team for rise in creatine. The creatine bumped from 1.2 to 1.9, and the urine output is decreasing. And then we call nephrology team. The nephrology consultant was on leave for 7 days. He comes to the hospital after 7 days after Diwali vacation. And then the first thing he does is write meropenem or polymyxin. He's not interested to write about the rise in creatinine and what's going on and the need for dialysis or not, which is more pertinent and specific for a nephrologist. But we all are so much focused on antibiotics, which we need to check. Also, some people, we think that most of the consultants know many things, but many of them still do not have like adequate knowledge about toxicities, about antimicrobials, especially amikacin, vancomycin, polymyxin. So they're drugs. We need to monitor the toxicity and use them properly. Another challenge that we are facing is surgical prophylaxis. Our surgical colleagues say like we need to use antibiotic prophylaxis for 7 days. If we need antibiotic prophylaxis for 7 days, then we need to check our operation theaters. Are we doing things properly? Are cleaning, sterilizing things properly? And surgeons, most of the time, they say, I think there is contamination, which we feel that we don't have to think for contamination. We just see if there is contamination, there is contamination. If there is no contamination, there is no contamination. So we have that common challenge also. Another challenge that we face is delay in receiving antibiotics. The consultant commonly blames the antimicrobial program or the pharmacy for not delivering the antibiotics and tells that to the patient family. So they say, like, who will take the blame if the patient does not do well? And that commonly happens in a private hospital or a private corporate hospital. And then we have tried to solve that with keeping some drugs as emergency stock of 2 doses in the ICU or ER so that they don't have to wait for the first dose of antibiotics. So we have some stocks like of 2 doses of those antibiotics in the emergency and the ICU. Other challenges that we commonly think in Nepal are in-house pharmacy. Most of the public hospitals in Nepal do not have an in-house pharmacy. And we have very, very few clinical pharmacists who can probably handle this program, and will need some trainings. We also have very few infectious disease specialists. So now we are working in the ASP team, like intensivist and internal medicine doctors. We are working in the ASP team. Also, another challenge that is faced is the remuneration to the ASP team. Like, what will the ASP team, approval team, get by, like receiving phone from morning 8 a.m. to 8 p.m. And we try to give some financial remuneration, but like the hospital where I work is now like totally supportive, and so we have been able to do that. But for when we plan to start this at other hospitals, the first question is like, who will pay the remuneration? How we cannot charge the patient? How this will be helping the hospital income? And like that, those things are they come into question. And in fact, few hospitals even say that by this you are decreasing the sale of my antibiotics, which is one of the source of income in my pharmacy. So those things usually come up, whereas we have been able to do this in our hospital as the management has adopted this policy at Grande Hospital since last 5 years, and we have been doing it very smoothly. So these are the challenges that we face. And now I think almost toward the end of my presentation, the goal of our ASP program is to decrease unnecessary use of antibiotic, inappropriate irrational antibiotic use, ensure correct dosing frequency, correct use of antibiotic therapy, minimize antibiotic drug resistance, decrease the risk of side effects and toxicities, and decrease the burden of the cost to the patient. This we try to explain our hospitals, manager, policymakers, and overall improve patient care and improve patient safety. Thank you very much for your patience and time. I'll be very happy to take any questions. Thank you.
Thank you, Dr. Acharya, for sharing all those practical aspects of interesting challenges and with regard to even resources and behavior, which you, and even including remuneration, which is an expectation regarding the practices of antimicrobial stewardship in Nepal, and especially in your hospital, with your experience. Thank you so much, and please stay on for Q&A at the end of this session. With that, I would like to now go on to our next speaker, which is Professor Dr. Satish Kumar Dio. Dr. Dio, are you there? I think I better look at the chat simultaneously, because I remember I noticed later that Dr. Acharya had written that he couldn't unmute. But I don't see Dr. Dio. Nikita, I don't think, is he there? Okay, anyway, I will introduce him, and we have his recorded presentation, so we could look at it. Let me first share with you about Professor Dio. He is currently rector of Madan Bhandari Academy of Health Sciences, a government university under Bagmati province, Nepal. Has specialized in clinical pharmacology in 2006 from the BP Koirala Institute of Health Sciences. He has served as editor of Nepalese National Formulary, DDA MOHP Nepal. He is an executive member of the Ethical Review Board of the Nepal Health Research Council. He is 2 times elected executive member of the Nepal Medical Council, National Coordinator for Rational Use of Drug, CPD Committee, again the Nepal Medical Council, and member of the National Technical Working Committee, AMR MOHP, and president of Alliance Against Antibiotic Resistance at Kathmandu, Nepal. So, Nikita, let's over to Dr. Professor Dio's presentation. Let me put it up.
Namaste and good evening. Thank you so much for giving me opportunity to present on workshop on implementation of antimicrobial stewardship in resource limiting setting. My topic of presentation is challenges to opportunity for implementation of antimicrobial stewardship program in Nepal. I am Professor Dr. Satish Kumar Dev, MD Clinical Pharmacologist, and presently working as rector in Madan Bhandari Academy of Health Sciences in Arora, Nepal. My journey so far was I am editor of Nepalese National Formulary, chief editor to Code of Ethics 2017. I had the opportunity to work for Nepal Health Research Council as an ethical review board member, and I was also author of 2 clinical pharmacology books, one mainly for an MBBS student or nursing student. Before I proceed for my presentation, I would like to thank Dr. Pooja Sharma, Dr. Anita Arora, and their entire team for their untiring effort to make this event successful. Antimicrobial resistance has been always a concern to a medical fraternity from a long time, but it has taken a very serious note when Director General of WHO, Dr. Margaret Chan, says that AMR is going to become slow-moving tsunami. From that day onwards, the priorities were more shifted to prevent antimicrobial resistance. So I'd like to start my presentation with a brief outline under the following headings. One is the introduction, challenges, and the opportunities. So, why antimicrobial resistance is becoming so important? And why this? Because it has taken up by global organizations like WHO and United Assembly, and it has already marked as a global health security issue. The primary idea here is to prevent, detect, and respond to prevention of antimicrobial resistance. Introduction. Before introducing about antimicrobial stewardship, I would like to introduce my country first. You all know Nepal is a landlocked country where its borders are India and China. India with an open border with a total population of around 29 million people. There is always discussion that what are the factors that is responsible for AMR in a global scenario, and probably the scenario are same in Nepal too. The one of the major factor for developing AMR is the overuse in the chicken and all for a growth promoter also in agricultural side as a pesticides, this leading to a overuse of antibiotics and developing a antimicrobial resistance. Though regulations say that it should be prescription based, but in Nepal, still antibiotics are prescribed as a OTC drug, and the self-medical practice is another reason for this development of AMR. The hospital settings may not be well equipped and for all microbiological tests as well as for appropriate IPC measures leading to antimicrobial resistance. And again, the good management practice is also important component that need to be addressed for antimicrobial resistance. Our countries have taken various steps for preventing antimicrobial resistance since 1999. National Public Health Laboratory has become a focal point for AMR surveillance, and AMR have a definite focal point in our Ministry of Health. Also, national antibiotic guidelines have been developed by Ministry. But with these all steps, the major steps was the development of a national action plan, which is primarily based on global action plan, and effective execution of this can prevent AMR and effective execution of a stewardship in Nepal. What are the challenges here? In my personal view, the challenges for national action in this stewardship and AMR are mainly based on national action plan only. Awareness and understanding, knowledge and the evidence, strategy 2, strategy 3, infection control and prevention control, optimize use and innovation and the research and development are the key strategy to prevent antimicrobial resistance, and the challenges lies within it only. For example, if there is a good surveillance of AMR with optimum laboratory mechanism and operational research, obviously strategy 4 antibiotic stewardship can be effectively ensured. Similarly, strategy 3 infection prevention control is, if they are automatically there, this stewardship mechanism will be properly utilized, and the antibiotics which can be regularly used and this reserve antibiotics, the use of that can be minimized. Similarly, awareness and understanding, not only for health workers, but other areas also is equally important. And if those things can be properly implemented, national action with this antibiotic resistance can be minimized. Another challenge I see is it's a One Health approach and it's a multi-sector involvement. The multi-sector involvement not only for a technical person, but also for a bureaucracy, also for politicians. So there is a big coordination required among these three important groups, that is human, animal, and environmental health, and that coordination is done by One Health, but effective execution is still lacking in our country. So this hinders the optimum new stewardship program or for antimicrobial resistance, prevention of antimicrobial resistance. Similarly, the challenge which I have already mentioned is the coordination among different stakeholders, political ownership. You all know it's have a multiple ministerial involvement, and this definitely leads to a difficulty as different ministries have their different perspective and the approaches may be different. Similarly, the monitoring mechanisms are not sufficient enough, and the data surveillance and surveillance part need to be also strengthened so that the interdisciplinary dissemination of the data can be done and AMR can be minimized. And with all these multiple involvement probably the financial involvement is also high, and that also need to be addressed for effective implementation. Likewise, the opportunities, I guess, is also same based on National Action Plan only, and these are, if we are able to develop appropriate awareness, this will lead to appropriate optimized use of drug and stewardship. Having a good knowledge of a surveillance and evidence base can reduce the use of antibiotics, and a stewardship program can be further implemented. IPC first key to approach for stewardship, and effective implementation of IPC is equally important for this, and this can be taken as one of the opportunity. Optimal use of drug, rationing of drug is also one thing which need to be done in multiple steps, and these are still in infancy. And this is also one opportunity, and the strategy 5 investment for a various AMR activity. And these are again not being addressed in our country, and in my view, antimicrobial resistance in promoting investment is one of the opportunity to prevent the antimicrobial resistance. Summarizing my presentation, I would like to say that our country has been working on antimicrobial resistance and antibiotic stewardship from many years, but with development of a global action plan by WHO and the national action plan by Nepal, Ministry of Health, along with the other government agencies like Department of Drug Administration and other organizations are equally working on it. But these are not only done by government organizations, but the academias are also nowadays involved for antimicrobial resistance, and the various activities and been started. Similarly, the other funding organizations are also working on it, and there are few organizations which have started antibiotic stewardship, but these are not sufficient, and the expansion of stewardships need to be done in a different government as well as a private setting in days to come. Thank you so much. Thank you for listening. Any question and queries? Please feel free to ask me for a open discussion session. Have a great evening. Thank you.
Thank you, Professor Dr. Satish Deo, for your enlightening presentation about the situation in Nepal and how you're handling it. We would now go on to the, please do stay on for Q&A. I have noticed that you've joined. Welcome, Dr. Deo. We will now go on to our next session, which is, just give me a second, which is the Indian team. And we have Dr. Anita Sharma and Dr. Amit Mandal, who will be talking on challenges to opportunities for implementing ASP in India. Let me take a minute to introduce them to you. So Dr. Anita Sharma is Associate Director and Head Lab Services and Infection Control at the Fortis Hospital, Mohali in India. She's a diploma in hospital infection control from the London School of Tropical Medicine. She's also, their hospital was the APSIC Hand Hygiene Award recipient recently, which was a great honor. She's on the editorial board of the Journal of Patient Safety and Infection Control. She's treasurer of the Hospital Infection Society of India, the Tri-City chapter, has been a faculty in various national and international conferences, and has contributed to scientific publications and chapters. Welcome, Dr. Anita Arora.
Thank you, ma'am.
Sorry, Dr. Anita Sharma. This always happens even in our own hospitals, and I've done it here again today. Sorry about that.
Absolutely fine. Thank you so much for the wonderful introduction. Yeah. So ma'am, I've sent a recorded version if it's okay if you can play that.
Yeah, we will play the recorded version. I will just first introduce Dr. Amit Mandal too, since the session is combined, and we will then start with your presentation, Anita.
Sure, ma'am.
Yeah. So Dr. Mandal is Director Pulmonology, Sleep and Critical Care at the same Fortis Hospital, Mohali, which is in Punjab in India, incidentally. He's actually a very keen, he has a very keen interest in infection prevention and control and in antimicrobial stewardship. He's, he participates so actively in our own internal, discussions, fora, and though he may not be, as he puts it, he has no honors or awards. I think that itself is a big honor and an award for us that, we have a clinician who's a pulmonologist and intensivist so interested in infection prevention and control. And being a clinician, that helps us in because, when he speaks to his peers, his other clinicians, they, as we all know, they would listen more keenly to a clinician than to any other specialty, whether it's sometimes even infectious disease and let alone microbiologists or pharmacists. He has contributed to the national guidelines on infection prevention and control and to the HESI guideline on central line associated bloodstream infections. And he has a few international publications and national publications. So welcome, Dr. Mandal. Dr. Mandal, you're on mute. Yeah. Right. So Nikita, I would request if you could first play.
Thank you so much.
Most welcome. So request Nikita, if you could play the presentation of Dr. Anita Sharma. Yes.
Well, good evening, everybody. And at the outset, I wish to thank the organizers for this wonderful workshop and for giving us this opportunity to talk on the challenges in the implementation of the stewardship program in a large and a diverse country like ours, which is India. So I'll be basing my talk and under these headings, and I'll briefly touch upon the Indian healthcare scenario along with its challenges, and then talk specifically about the challenges that we have in the implementation of the AMSP at various levels in the country. Just to reiterate that India is a huge country. It's the second most populous country with 28 states and 8 union territories. And healthcare is a state subject, which means that the implementation of all the health-related policies rests with the individual state government, and that sometimes can itself pose a certain degree of challenge. Now, if you look at the healthcare space in India, it's a multi-layered, providers are there. The public sector can be very nicely divided into rural and urban spaces, and there's a very well-defined hierarchy of the healthcare systems which are available in both these spaces. We see the focus, the concentration of the super specialty hospitals in the urban areas, whereas the primary health centers and the community health centers is what we see in the rural areas. The private sector is very well concentrated in the urban areas and ranges from small, clinician-driven nurse clinics to very large super specialty corporate hospitals. Now, needless to say, the expenditure that the patient incurs is much higher in the private sector, but in spite of that, about 70% of the care is provided by the private health sector in our country. And as a matter of statistics, out of the 43,000 registered hospitals, only about 2% or even less than 2% are accredited, with the stamp of quality. When we look at the healthcare expenditure and resources, as you can see in this graph, the healthcare expenditure of India is much less than even the developing and the other developed world, and even the healthcare worker density falls much below the global standards. Amidst these, statistics, if we just look at where we stand, we're a country of 1.3 billion, with very poor doctor to population ratio, and the hospital accreditation in our country is still voluntary. So thus, what we see is majorly overcrowded, under-resourced health systems with poor environmental conditions is what we see in our hospitals. Now, so therefore, amongst the key healthcare challenges of access, affordability, and critical workforce shortages, the life-saving treatment takes precedence over infection control and the AMSP activities. So with this background, let's look at what are the challenges that we face with respect to the implementation of the stewardship programs. And if you could just draw a list, probably there would be so many of them. And each one of them is a challenge in itself. And so I'll just go, go into them with some degree of detailing. The implementation of AMSP, as we all understand, is a complex issue in itself, and it requires the establishment of structure, processes. We need to address the attitude, belief, and mindset of the prescribers, and finally create an organizational culture where things are aligned and people are focused, and we are able to monitor, measure, and improve. And this system has to function from primary to tertiary healthcare. However, a lack of robust infection prevention control program, which we see in many of our hospitals, is a compounding factor. We understand that poor infection control practices lead to infections, and which lead to antimicrobials, which lead to resistance, and even in turn, the drug-resistant bugs that we see. And therefore, if we have to address these challenges, it has to be a two-pronged approach. Now, we often know that seeing is believing. We believe that. And for that, data can be a very powerful tool for the change management. However, what we see that in our country, we have limited research in quality data in the sphere of antimicrobial stewardship. In this article, which came out recently, and where they could only found 17 studies which was focused towards implementation of AMSP and the infection control and such. And out of that, only 35% had entire AMSP implementation. So thus, we do see a poor awareness and appreciation of the threat of AMR across the country. And that, I think, is one of the very big challenges that, how do we generate a good quality data which can be used for decision-making, policy-making, and change management. Having said that, the journey for India in AMSP started just about a decade ago from Chennai Declaration given out in 2012, but we have done some significant work, and in 2017 the National Action Plan on AMR was launched, and here also, which requires a cooperation across various health sectors, for reining in this huge problem of antimicrobial resistance. So again, the coordination and cooperation amongst ministries, amongst various legislations, across various bureaucracy is again, a challenging factor which needs to be bridged. So if you look at the AMSP implementation at the executive level, which I mean by at the government level, both at the center and the state, the biggest challenge that we see is a limited government mandate for a stewardship program. However, some work has started, in the recent few years, and we are looking forward to it being taken on a very serious note. But this one particular aspect has really, halted our march or our efforts towards implementation. Having said that, any such programs require skilled resources, and globally what we have seen is that stewardship programs are very well driven by the pharmacists or the ID physicians, and we do see that in a country as large as this, very few institutes are offering these MD with on pharmacology subject. So we definitely need to build up this capacity, and if we have to really take it very seriously at all levels. Not only that, we need good quality assured microbiology laboratories, which are, again, wanting, and not that, of course, we have the accreditation program wherein a lot of laboratories are now seeking accreditation, but still there are vast majority of laboratories which are just churning out reports where the quality cannot be assured. So again, this remains a challenge, in the sphere of the AMSP program. Very importantly, it's the easy and the over-the-counter availability of the antimicrobials, which causes a lot of concerns to all of us. However, lately, some legislation has been brought into the effect, and it has been mandated that the antimicrobials can only be prescribed if there's a valid clinical prescription for it. However, the implementation at the ground level is still lacking, and therein lies the challenge that how do we make sure that the policies which are created, which are good policies, how do we take them down to the grassroots level to make them effective? The lack of standardization in clinical practice has been the norm, and each one to their own. And yes, the guidelines are there, but when it comes to individual practice, there could be a lot of gaps out there. So therefore, the guidelines based upon our own milieu, about our own, problems, about our own data is extremely important. And I think the guidelines that have come out recently, they need to be taken down in letter and spirit for implementation. And how do we do that? It remains, to be seen, and it's a challenge for all of of us. In the end, it's the governance mechanism that needs to be strengthened. We have limited public and personal accountability as yet for the AMSP program, and therefore we need to make sure that some accountability is fixed in the entire hierarchy, starting from the primary to the tertiary care structure. When we come to the individual organization at the hospital levels, there are innumerable challenges again. And if you look at the public sector, there is a huge problem of overcrowding. Our healthcare resources are limited. There's a poor infection control practices. There are inadequate manpower. So these it's in itself, prevents the implementation of AMSP in a very practical manner. On the other hand, the private sector, which is supposed to be resource rich, happens to have some other drivers, like, for example, the pressure for favorable patient outcomes is very, very high, and they have very easy access to even the high-end and antimicrobials. However, the one common theme across both the sectors is a lack of an organization structure and driver for these stewardship programs. So thus, at the individual organization at the hospital level, there is no mandate to have an AMSP program other than the accredited hospitals. Now, these accreditations have done a lot of good things to the hospitals. That means they have given them a roadmap. There is some kind of focus. There's some kind of accountability and ownership fixed onto the hospitals. However, the hospitals which do not have this kind of accreditation, they would probably could do good with having some moral commitment from the leadership. But what would be their driver? Most of the such non-accredited hospitals do not have any such committed individuals, who could drive this program. These champions need to be incentivized because they would be spending some time, and the approach to the patient management has to be multidisciplinary. So all these, important factors which are required for establishing an AMSP programs are lacking in the absence of any commitment from its leadership. And of course, we do understand that a lot of data management needs to be done, and we need to understand how we are doing for improvement. We need to collect data. We need to turn them into good information. But sadly, most of this data collection, collation, and analysis is done manually in many of the hospitals where the program is also being run. So what to speak of the areas where the program is not available. So again, it's a huge, I would say, deterrent, to find out that kind of time to devote to this kind of program. So these are the challenges that we see at the individual organization level. But the most important thing is that a clear mandate from the leadership to conduct these programs. So I mean, recently a survey was conducted in about 20 hospitals, both public and the private sector, to understand and to look for the presence of these core elements for AMS across these hospitals. And as you could see from the data, that only about 50% of the hospitals could meet many of these core elements for the stewardship program. And in fact, even in them, it was these programs was largely implemented in the private and the accredited hospitals rather than the university or the public health hospitals. So there's a great divide here. And what really comes out very clearly is that on all these hospitals in our country, the accreditations have been a great enablers for the AMSP implementation, which in fact is voluntary, and very few hospitals have taken this path. So therefore, some kind of driver, from the federal leadership is required to make these AMSP programs mandatory, which is still not there. At the prescriber level, because at the end of the day, it's a clinician who's going to be writing these antimicrobials, and we all understand, and the physicians do understand, that AMR, an inappropriate antimicrobial prescriber, is a problem nationally and internationally, but they're a little less concerned about it in their own practices. And why is that? Because one is their major source of information once the doctor passes out of a med school is the pharmacology representative, the pharmacy representatives, the pharmaceutical representatives, and in the absence of a good mechanism to learn about more about these antimicrobials, that remains the major source of information. Not only that, the point of care test or lack of good access to good diagnosis, prevents a very evidence-based prescription, and largely it turns into an empirical management of the patients. But most importantly, it's the fear of infections and the legal liability that really drives this kind of a overuse of antimicrobials, because in India, the responsibility of outcomes still rests with the primary physicians. Besides that, there could be some external pressures in the form of the patients and the pharmaceutical companies to prescribe antimicrobials. So these are the challenges which are present at the level of the prescriber, and majorly stems out of the knowledge, attitude, and behavior. And a good amount of studies have recently come out where they have highlighted these challenges of prescriber in our country. Then coming to the community level, because a lot of care gets driven at the primary healthcare level, and here what we have as a system is people, or what we call as providers, with informal training, providing these healthcare to the people at the very basic level, at the villages, and so on and so forth. And in fact, these providers with informal trainings are the first port of call for medical needs, including antibiotics, because we don't have enough trained medical practitioners available at that level. And in fact, it has been seen that 50% of these clinical encounters may end up in an antibiotic prescription, which many times is haphazard with respect to selection and dosing. The factor that their livelihood of these PI sometimes can depend upon these prescriptions, because they often believe that without antibiotics, the patient is not going to get cured and they will not come back to them again, and therefore it will adversely affect their income. And when we look at the prescription practices, it's a standard dose of amoxicillin or cefoxitin given for 2 to 3 days for all fevers that may be presenting in the community. So for these kind of healthcare providers, it's the pharma industry and the formal doctors which produce this antibiotic knowledge and practice. And on the weak health and the regulatory systems that we have in these places, they kind of exert limited checks on these kind of practices. And finally, to add to all these challenges, we have our own beliefs and cultural practices with respect to antimicrobial use in the community. As a country, we love to give advices. And especially in the space of antimicrobial space, we often self-medicate, and people often feel emboldened to give advice on antimicrobials based on their own experiences. So therefore, to summarize in the end, if we have to look at the various challenges, which are huge, but if we could just organize them into some sectors, they are multifactorial and multidimensional, and they need to be addressed at multiple levels, starting from right from the top, taking down to the community level. And the challenges, at the very executive level, could be with respect to the government policies, mandate, and their implementation, research. At the state level, it could be the infrastructure with respect to the availability of the skilled manpower, the lack of diagnostic laboratories, the lack of IT support, the lack of a surveillance mechanism and a reporting structure. At the organization level, the challenges are majorly to do with the leadership accountability and creation of structure and processes and measurables in their own milieu. And the prescriber, of course, is all about how do we the challenges associated with the knowledge, attitude, and the confidence that the prescriber needs to generate to ensure that they are completely in the program. And finally, in the community, we are still to talk about it, and we do not have any such huge social awareness campaigns of antimicrobial usage and resistance, and that we have seen some social campaigns, for example, like COVID-19 or hand hygiene. A lot of work has been done in that space, and something similar to that is still not there in our country. So therefore, the challenges are many and requires both a top-down and bottoms-up approach to address that. With this, I close my presentation. Thank you very much for your time.
Okay. Thank you, Anita. Thank you, Dr. Anita Sharma, for that excellent presentation. You've covered practically every aspect of challenge, right from public to private and nation to individual. With that, I thank you so much, and please stay on for the Q&A session. And now over to Dr. Amit Mandal. I understand you're going to give a live presentation, so would you like to share your slides?
Yeah. Yeah, thank you so much, ma'am. It's been a wonderful hearing the experience from Philippines, Bangladesh, and Nepal, and I hope that I'll add value in terms of dealing with the opportunities that exist as far as India is concerned. So this is the flow that I would probably go through. Look at the opportunities for successful implementation. Look at the models that have already been ongoing in the country. Look at the interventions which have been done at the national, state, and even at the local level, and then briefly go through our experience and then conclude. India is a vast country, the poverty to the rich, the large to small, and from completely small villages to the high-end metro cities that we see. There are huge challenges in terms of, so the opportunities that we would probably talk in terms of national, state, organization, prescriber, and community, all of them probably fulfilling different parts and different roles. The national in terms of the policies, research, and regulation, the state primarily, mind you, health, as Dr. Anita just mentioned, that it's a state subject. The state is kind of going to be dealing with the infrastructure and capacity building. Organization-wise, it could be the public sector as well as the private sector organizations, where they are supposed to be dealing with their own and designing their own programs in terms of whether it's an IPC program or probably an antimicrobial stewardship program, and look at the governance mechanisms. In the prescriber, we would probably look at predominantly the behavioral change that we all want to look forward, and that's when that will come with CMEs and learning, trying to learn new skills and thereby gain confidence. In terms of the community, the whole idea would be to kind of, in India, there are areas where certain drugs are not available, and there are certain areas, as just mentioned in the while ago, that the tremendous excess of the medications. So in terms of harnessing opportunities at the national level, yes, there is a national action plan that has been enrolled a couple of years back, which tremendous focus on surveillance data. There are treatment guidelines which have been enrolled out in the last couple of years. There's a lot of focus on One Health, but there's a lot of work that needs to be done, and predominantly from the point of view of coordination of all the different resources. Significantly, though we are an IT a powerhouse in the world, but when it comes to antimicrobial or even the healthcare sector, IT support is very, very negligible in most of the sectors. In terms of the state, yes, a lot of medical colleges are coming up, and that would probably be the fulcrum for skill training and so on and so forth. The organization one, yes, as I said, that they would need to probably look at not only having their own policies, but looking at accrediting, and probably now, as of now, as Dr. Anita mentioned, that it's voluntary. Down the line, we probably need to think in terms of making it mandatory and look at how we could probably keep auditing and measuring our goals and then moving forward. In terms of prescribe, I just said that we need the behavioral change that needs to be seen, and that can only come from academic meetings, looking at possibly credentialing and look at a multidisciplinary approach. So far, it's an individualized approach, my patient, your patient, but that probably needs to change, and that's just something that is seen in the Western world. Into the community, as she also elaborated, and in our part of the world, a prescription, unfortunately, is not complete till an antibiotic is prescribed for any fever, whether it's a viral or a bacterial, irrespective. So, in terms of the opportunities going forward, if you look at the systems, leadership commitment, there are plans and strategies in principle, but we need to see that in practice in terms of fund location, dedicated resources, and provisions for training and educations, trying to build up the skill training at that level. In terms of the systems, we need to have regulatory mechanisms, not only to implement the policies that are being designed and the programs that are designed, but also to ensure the quality, and a lot of intersectoral coordination, which needs still to be done. Infrastructure-wise, most of the things are probably happening at a national level, but I think the information technology support, which is so lacking in most of the centers, needs to probably go much, much higher. In terms of antimicrobial stewardship interventions, there are, in the private sector, there are multiple players, corporate houses who have these policies because they are all accredited, whether it's NABH or the JCI, they have accreditation, and that is what drives them. There is a lot of scope for public and private partnerships, and of late, the medical colleges, which are now increasing in number across the country, will probably be the fulcrum for further gains. Looking at the various models of the antimicrobial stewardship that have been used, this is from Dr. Sanjeev Singh's center at Amrita Kochi, where it had centered around a clinical pharmacist, and they had an AMS team completely looking after, and they did go on to suggest, publish this their experience, and where they did so that the clinical pharmacist-driven stewardship activities did decrease the antimicrobial consumption, and this is one model that could be looked at. The other model is, which was published from PGI, was looking at the teaching hospitals, the medical colleges, even at the secondary and the tertiary care hospitals could probably lend a hand to the smaller hospitals, which are probably the district and the community hospitals or the smaller centers. And that is how probably we could probably stretch, not only skill train these people in terms of IPC and AMSP practices, but also probably be a guide to them. At the national and the state level, yes, this was a slide delivered by Dr. Anita also, and that the National Action Plan has been in force. And since 2012, yes, we have traveled a long distance. In terms of the research and in collaboration, yes, the country has done well in trying to collaborate, but what needs to be further done is in terms of the learnings from these research programs that have happened to trickle it down to the ground level. And that's where probably we can gain most. In terms of controlling or trying to control the misuse of inappropriate drugs, there has been some gains in terms of inappropriate fixed doses and the ban of colistin in the animal feed, which was a huge gain for us. And of course, in the of late, antimicrobials, as was shared by Bangladesh and Nepal, it's out of anybody can buy from anywhere over-the-counter medication. And in terms of, there is a red line and a Schedule H for antimicrobials, that is, which means that a prescription is mandatory. There are guidelines which have been published last year. The National Guidelines of Infection Prevention and Control across healthcare centers was published, and treatment guidelines, which was published about a year ago. But yes, these needs to be trickled down at the ground level. In terms of awareness programs, yes, a lot needs to be done. Thanks to Swachh Bharat Abhiyan, there is a lot of, in terms of cleanliness in the community, there is some trickling in, but not to the point that we see a visible change. And of late, that has been stretched into the as kalp of the for the hospital scenario. When it comes to state action plans, the Kerala was the first one to probably lead across in terms of generating their own antimicrobial resistance strategy action plan in 2018. It was followed by Madhya Pradesh in 2019 and in Delhi in 2020. So there are more states in vogue in the pipeline, but yet to see the final declaration. Now, One Health approach across the world, it has been the way that in an effort to look at human, environment, and the animal kingdom together. If you look at the program, it goes right down to the village panchayat, and it has a lot of ministerial involvement. It has a lot of public and private medical institutes all involved, which means that there is a whole lot of coordination which needs to be done. It looks perfect on paper, but needs a lot more coordination for it to be effective. One of the criticism for this is that it is probably disease specific and probably suited best for pandemic durations, and that is what is the big challenge and the opportunity to make it more sustainable. We have an integrated disease surveillance program ongoing across different states and districts, and this probably could be empowered in terms of looking at or running the surveillance program for MDR infections and looking at the AMSP surveillance programs and the programs. In terms of the capacity building and strengthening of the infrastructure, thanks to COVID, only the bright spot of COVID is that it has made national healthcare in India a focus. As I just said, the national guidelines for IPC in healthcare facilities were published in January 2020, and there was a training program across 6 individuals from 10 states across the country had come over last month, and we were all involved in running the training programs, and subsequently it stretched down to the districts and the community centers. Next, a lot of work at the government level is being done in terms of the medical colleges coming up, the healthcare sector skill councils, as well as the integrated government online training program. These are all adding to the skill training, which is so required and deficient as of now. Corporate hospitals, private hospitals, we are already involved in building on the job competencies to ensure that we have better outcomes. And that means that there is a lot of scope for public-private partnership. Accreditations of hospitals, which are so far kind of voluntary, needs to probably be made mandatory, because this is going to be a game changer in terms of bringing on a paradigm shift in terms of the care provided, in the standards of infection control that is followed. And probably that's where we'll get a boost to the antimicrobial stewardship program. And it should not include only the larger hospitals, but also the single specialty centers, opthal, dental, dialysis centers, and so on and so forth, and even the diagnostic centers, which are so many in our country. At the organization level, this is what we did. It's something that all of us will probably have to look back as to how we can probably build and look into how we can implement our AMS program. It's not what needs to be done, which is probably how we do it, in creating the team, building on the existing infrastructure. People would have challenges in the public and the private sectors differently, smaller hospital, bigger hospitals. We need to set the goals and try and achieve the smaller ones and easy ones, which are easy to probably achieve. Look at creating champions and see if we can probably divide our work and maximize the teamwork, and probably look at empowering and encouraging people to become champions, and look at the challenges or the difficulties and keep auditing, looking at, ensure that we look at the feedbacks, and that's how we probably improve. And it has to be owned. If you look across the journey, we began somewhere in 2008, where we created the antibiogram, antibiogram, and then also had some sensitization with these clinicians, went on to formulate the SP guidelines. Then there was a consensus document that was taken out in 2009. 2010, we kind of did the audits. 2011, there was a surveillance program which extended to general surgery, and thereby initially, and then subsequently to all the surgical fields. And this is where the corporate started coming into the picture, where they launched the AMS program at the corporate level. And subsequently, in the next 4 or 5 years, they went on to form the Fortis, which is more than 20 hospitals across the country. Antibiotic policy, the antibiogram ensure that every unit had their own respective antibiograms. There's one slide that I would probably allude to in regards to the drug resistance index, which is basically, I'll come down and probably explain that. The whole idea was to bring about a pan-Fortis focus, where there could be some governance mechanism from the central level, and look at how we could create a core team, which could be a guide to all the respective hospitals. Subsequently, in the next 3 years, there was a revised antibiotic policy, which was syndrome-based. So we went on with the surgical prophylaxis, formulated them, and probably look at the restricted antibiotics, and designed a justification form for all the units to kind of follow. This is the time that we also looked at creating our de-escalation program, and looked at, see if the IT could help us, which was some support, but not optimal. We did try and increase our clinical engagement. We enforced education, CME programs to ensure that more and more people get on board. We did a point prevalence service, which I'll just mention in a while. And just about in the last 1.5 years, there was a creation of a dashboard. I'll just allude to that on a particular slide, which is basically for the corporate team to understand. And this is basically empowering us so that the directors or the heads of the hospitals, which could be medical or non-medical, will be, it comes under the KRA to ensure that this is a kind of focus. This is a lot of the activities, not across just the paramedics or the medical people, but medical team members, but also amongst the public. And there was some leadership around which took place to ensure that the program was being appropriately followed. In terms of quality improvement tools, yes, all of us, different units, different hospitals will have our own challenges. We need to probably look at the gaps that we pick up. We need to have pre-intervention audits, look at how we could probably resolve them, which means that look at the interventions, try and see if we can make those changes, and then again do an audit and feedback. And then if we have gained on, we need to consolidate in the post-intervention period, and that's something that we need to do. This is just a thing on it's a happy story, the surgical prophylaxis, but if you look across TCare, there's still some scope for improvement. And out of the 4 or 5, we have had scored pretty well. It's been a happy story from where we started about 6, 7, 10 years back. And we are proud to be, there are challenges. I'm not saying that's a 100% perfect story, but there are challenges for further improvement here. This is the point prevalence studies that we had done. This is the process metrics, and these are the outcome metrics. Process metrics is all about before the antibiotics are initiated, have we risk stratified the patient? Is there a differential diagnosis which has been mentioned on the file? Is there a rationale for the antibiotic provided? And have the appropriate cultures been sent out before the starting of the empirical antibiotic? And this is the outcome metrics that we follow since the last 5 to 6 years' time. Last couple of years, one of our clinical leads did stretch out a program on de-escalation, which is a bone of contention, is because nobody wants to de-escalate from a broader spectrum antibiotic to a narrower spectrum antibiotics. And this is just to show that, yes, engagement, clinical engagement at the bedside with the case file can probably help us in terms of de-escalation. It's not a very great story, but yes, from 30%, we could raise it down to 70%. And this is something that requires further improvement on. Briefly, as I just talked about, drug resistance index is just simply something like the census index of India. It's just a function of the antimicrobial resistance and antimicrobial consumption. It just basically means that a score of 1 is that in that particular organism, there are no further antibiotics to be treated with. And if the ideal figure is less than a 0.5, the whole idea was to bring in the senior leadership, which could be non-medical people who could probably understand what it means and bring about some sense of governance and involvement. This is how the corporate probably sees them from different units. And this is the unit antimicrobial dashboard that has been created. Some parts looking at the administrative function in terms of whether there is a functional AMS working group meeting that's happening on a regular basis. Are there CMEs happening? Is there an antibiogram? Is that an antibiotic policy which is being upgraded or reviewed on a regular basis from year to year? Also look at the surgical profile access summary and the restricted antimicrobials. Also look at the antimicrobial utilization specialty wise. And this is assessed by the corporate on a monthly basis, and in the hospital, in our hospital, as well as in the across the at the corporate level, Fortis Medical Council review. In terms of the prescriber and the community level, the big thing that needs to be done is that try and integrate these small and medium-sized private sector players, or even the public sector players for that matter. Try and formulate easy guidelines for them to follow. We should ensure that we are not increasing the barriers to the access to drugs, but rather curb the excess, and probably build about a training program where we can balance not only the pharmaceutical promotion, but also expand with antibiotic stewardship practices. And it's the whole idea, as I said, is improving the access to prevent the excess. Public awareness, as I just mentioned, a prescription in India with fever is never complete without an antibiotic, and that concept needs to change. And for that, we have had some sporadic social awareness programs, but I think more needs to be done. So the second last slide, at the national level, more coordination is required amongst the various bodies. There is a regulation which is required for the over-the-counter availability of antimicrobials. The advocacy needs to follow the budget as well as the in practical application at the ground level. IT infrastructure and support framework needs to be tremendously improved. In terms of the state level, it has to play a significant role with the secondary hospitals and private players in the AMS program. They need to strengthen the diagnostic labs further, improve the diagnostics in an availability in a manner that we can probably look at basically early diagnostics, where we could probably look at whether the patient needs an antibiotic or not. IDSP has a big role to play, and I think the state should work on that. In terms of accreditation, there should be mandatory accreditation for all healthcare facilities, irrespective of the number of beds or the hospital. And the skill training should be skill training should be done on a public-private partnership. In terms of the organization, accreditation, and focusing on the AMS and the IPC programs, at an individual level, we should all look for behavioral change. And as I just said, in the community, we need more and more awareness programs. Collaborations, as was said by other speakers previous to me, are the key to success. And with that, I thank Dr. Sharmila, Dr. Anita, and Dr. Sanjeev for the wonderful opportunity. It's been a wonderful learning all throughout. Thank you so much.
Thank you so much, Dr. Mandal, for that extensive, exhaustive presentation, covering so many aspects in this short time. Please do stay on for the Q&A session. I know we're getting a little late, but I know everybody's trying to, really rush through their presentations. There is so much to talk and so much to discuss. Thank you so much once again. I will now go on to the next speaker. And I would like to introduce the penultimate speaker for the penultimate day, Dr. Pooja Sharma. She is the director and head at Medanta Institute of Education and Research in Gurgaon, India. She's a well-renowned scientist, having been in the field of research for over 15 years now. Incidentally, you know, she's the organizer, one of the organizers too. Prior to Medanta, she has worked at AMS and the All India Institute of Medical Sciences and the Society for Applied Sciences as a senior scientist. Her expertise lies in protocol development, clinical trials, and research ethics and public health research. Welcome, Dr. Pooja. And yes, let's have her presentation.
Thank you so much, Dr. Anita, for the very kind introduction. It's an honor and an opportunity for me to be sharing the outcomes of an experience that we had at Medanta. Kita, is my application slides visible?
Yes, ma'am.
So I would like to share with you today our experience of the application of a comprehensive unit-based safety protocol to improve antimicrobial stewardship. So this was the whole team. I must appreciate the effort that was made by them during this exercise. It included microbiologists, pharmacists, clinicians, critical care physicians, IT professionals, data managers, researchers, and statisticians. It required a whole village to actually create the CUSP team. Of course, I'm not wanting to repeat the background even more than it has been previously shared in the last 3 days of the workshop. Infectious disease burden is high, and it's among the highest in the world. Indiscriminate use of antimicrobials is prevalent. And given our population, inadequate stewardship results in India contributing disproportionately to the global burden of antimicrobial resistance. Implementation of hospital-level antimicrobial stewardship in India is still relatively primitive. Medanta has initiated a robust antimicrobial stewardship program under its NABH and JCI accreditations, although the cooperation and translation within the healthcare teams limits its impact. So our discussions on how to improve this program with the Hopkins team led us to exploring the CUSP for antibiotic stewardship. CUSP is a comprehensive unit-based safety protocol, a strategy which is used to self-identify barriers to patient safety across medical disciplines in order to address patient safety issues. It emphasizes as a concept the culture of patient safety by proactively recognizing adverse outcomes, introducing a structured environment to learn from mistakes and best practices, and promoting a culture of safety within the teams. CUSP has been used in the US to target a wide range of hazards, including patient falls, hospital-acquired infections, medication administration errors, specimen labeling errors, teamwork, and communication breakdowns. One such project, called the On the Cusp Stop BSI, actually reduced central line associated bloodstream infections in 44 US states by 40%, while saving an estimated 500 lives. So at our institute, we actually submitted this as a research project. It was called the application of a CUSP program to improve antibiotic stewardship at a tertiary care hospital. Funding for the same was provided by the Pfizer International Academic Grant, the AHRQ, and it was approved by our Institutional Ethics Committee under the principal investigatorship of Dr. Yatin Mehta, who is the chairman of critical care and infection control. So CUSP as a strategy seeks to self-identify barriers to patient safety and uses an introspective and a data-based approach with real-time feedback to encourage behavioral change. It includes several soft skills trainings as well as basic statistics trainings. The first aim of our research project was to help treating teams self-identify barriers to rational antibiotic use by using the CUSP approach in selected ICUs. So we selected 2 ICUs. These were our mixed ICUs. And a total number of 44 beds. The second aim was to provide feedback and attempt to address the barriers identified by the CUSP program and to reduce antibiotic use in selected ICUs. Third was to use and improve a customized AI-enabled mobile app as a tool to help stewardship practitioners identify and address inappropriate antibiotic behavior. So under the first aim, the operational steps included creation of a structure of stewardship, which we already had a basic structure available. So this was not something that we really needed to put too much time and effort into. But we also needed training of the team on cusp strategy. This was conducted by the team from Hopkins online. We also had to define regular data collection processes and summarization of this data collection to prescribing teams. So when the data would be presented in joint meetings, what was it that they would like to see? The cusp team ensured data collection was done daily in these ICUs, and the feedback was then planned through the cusp ASP feedback meetings. We work to design interventions, provide education to address concerns identified in cusp, and implement the processes using a team approach. The Antimicrobial Stewardship app actually included this flow of events. And finally, how the empirical therapy would be converted into a definitive therapy, as well as how the algorithm would actually be modified with data that would come in through our clinical use and clinical data collection. So our primary outcome measures were change in proportion of an irrational antimicrobial prescription over time, assessment of clinical justifications provided, track number of deviations over time, track rate of de-escalations of therapy, and secondary indicator outcomes were change in antibiotic consumption patterns for restricted antibiotics, days on therapy, route of administration, and appropriateness of drug chosen. The AMS app utilization by stakeholders was also one of the outcome measures. Data management was done through the app itself, and the antibiotic use was divided into 3 categories upon review by project microbiologists and the clinical pharmacists. This included empirical, that is based on clinical evidence, definitive based on culture results, and then de-escalated. Once this data was collected and reviewed by the project microbiologists and clinical pharmacologists, this was actually then shared with the team. The cusp team would share this on a regular basis with, so this would include the team leads, the nurses, the microbiologists, the pharmacists, the data managers, and the clinicians who these patients were admitted under. The results of each patient were actually discussed in this manner. So the microbiology sample, the imaging, the antimicrobials that were used, the change in antibiotics that was antimicrobials that was noted, the whether these were appropriate, inappropriate, what was the dose, the dosage pattern. While this activity was happening, COVID-19 hit, and that actually converted our mixed ICUs into COVID ICUs, and the activity had to take a pause. Despite which we were able to actually complete the training on app usage to all intensive care nurses, medical officers, physicians, pharmacists, pharmacologists, microbiologists, and statisticians who were taking care of these 2 mixed ICUs. The app adoption trends were actually seen to increase significantly over the April 20 to March 21 period. About 500 ICU patient data was reviewed from April 19 to April 20 to actually see appropriateness of antibiotic use through our CDS algorithm, and then to actually create this algorithm for empiric and directed therapy using the CDS app. The COVID-19 pandemic and the subsequent conversion of the ICUs prevented validation of the app and assessment of the impact of the cusp study. So while the assessment was not completed, yet the challenges were very, very glaringly obvious. The challenges actually included interdisciplinary communication, soft skills, and actually conclusions and discussions over development of valid and meaningful safety-related measurements and outcomes that teams would like to see for review. It requires an immense commitment from the management and seamless communication within clinical teams, microbiological teams, pharmacology teams, data management teams to create and run a successful program. This effort would definitely not have been possible without funds, because the funds that actually supported one clinical pharmacologist, clinical pharmacist, data manager, the development of the app, specifically for the project. If that were not the case, then I do not know if so much resource or time could actually be spent on looking at appropriateness and then a communication back with the team, looking at data, looking at publications to actually ensure that this communication was in a non-threatening manner. I believe that this might be one of the most rate limiting factors for most antibiotic stewardship programs in resource limited settings. The second feeling that I have, and this is my personal belief, is that the passive support of management is not enough. Antibiotic stewardship policies actually need to be driven by them. So unless until the management pushes them, like we heard on the first day from the Singapore speaker, I do not think that it will be so easy to accept these programs in India. Our publication is being finalized and we hope it will be available soon. We will definitely be sharing it with you as soon as it's available. Thank you so much.
Thank you, Dr. Pooja, for that excellent description of your project and its success. And we look forward to the publication and we hope to see you in the Q&A in case anybody has questions on your on the cusp and how you did it and needs more details. With that, we come to the last speaker of the day. Has been waiting really long time, Dr. Wattal. So Professor Dr. Chand Wattal is, let me introduce him. He's Chairman, Institute of Clinical Microbiology and Immunology, Sir Gangaram Hospital, New Delhi in India. He has several awards which he has received: the Hospital Management Asia Award 2002 for Best Hospital Infection Control Programs, Dharma Veera Award for Excellence, S. Nandi Award as the Best Publication, a Long Distinguished Service Award by Union Health Minister. He had a Best Publication of the Year in Virology and the IAMM Endowment Award. He's currently the president also of the IAMM, that's the Indian Association of Medical Microbiologists, and the editor-in-chief of the Indian Journal of Medical Microbiology. He has been a treasurer and twice and secretary of the IAMM. And the chair, he is currently also the chairman of the EQUAS program, which is for laboratories for microbiology, clinical microbiology. He has had more than 35 years of experience in this specialty, has more than 100 publications in national and international journals, and has delivered or chaired more than 200 odd sessions and lectures. So welcome, Dr. Wattal. We look forward to hearing from you. Dr. Wattal, you're on mute. Nikita, do you have his slides? We could put them up and he could go through them.
Ma'am, shall I share it or Dr. Wattal will share it?
Dr. Wattal, would you be sharing the slides or shall Nikita share it? You're on mute, Dr. Wattal. I can see him as most of you can, all of you can, but Dr. Wattal is still on mute. Even if we put up the slides, I don't think we have a recorded presentation, right, Nikita?
No, ma'am, we don't have the recorded one.
Yeah, right. So let's just give him a minute. Maybe he's having some network concerns. You could put up the slides, I think, though. And Dr. Wattal, can you hear us?
Anita, why don't you just text him? Maybe.
Yeah, I'm doing that. Yeah, I'll just do that. Nikita, by any chance, would we need to unmute Dr. Wattle, or would he be able to unmute himself?
Ma'am, he is the co-host now. He can unmute
He can unmute himself, right? I have sent him a message. Let's hope he reverts.
Hello.
Yes. Hello, this Dr. Wattle.
Yes, yes. I'm very sorry. I was in the transition. And you just finished when it was the transition finished.
Right. So would you be presenting from your end, or shall we put up the slides here?
Let me try. I think I will share my slides.
Right. Okay.
So let me see if I am able to share, because I had tried to do that. If not, then
yeah, sure. Do try from your end. Otherwise, of course, we can put up the slides.
are you able to see?
Not yet, Dr. Wattle.
I have selected, but it is not showing my. Can you see it now?
Not yet. Would you like us to put up the slide? I mean, Nikita can put them up.
We are already very late, so I would not like to waste the time. I don't know why this is not sharing, though it is showing the screen here with me.
So you can press the share button in the right.
That's what I was doing, share button. I selected the presentation.
No problem. I will just share it.
I think that's fine.
Yeah, Dr. Wattle, your presentation is up, and I guess you can see it.
Slideshow.
Yeah, you can go ahead, please.
Put it at the slideshow. Yes, thank you very much. I think we skipped some of the slides. Did we? Okay. Now, you see, I have been given the a task of talking about the barriers in low middle income countries. I think we all, whosoever I was listening to, were from really from these kind of areas, and it was by and large you will find some of the repetitions, as I am the last speaker by and large. I was just wondering as to what are the real barriers that we really see in our area. You see, what has happened is we all are having defensive practice of medicine under the shadow of Consumer Protection Act, and patient has become a consumer and doctor a shop owner, which is very sad, and compassion has taken over by business. As a result, you know, to have a behavior change is not very easy, and to get a behavior change, this takes time. So there are no shortcuts to that. As was repeatedly told by previous speakers also, that there is lack of resources, and more of a perception needs to be created that to create resources when it is not really very resource intensive area. Sustainability of this program can be an issue. You will see in some subsequent of my slides. And then we also find in our fellow colleagues that there is a poor subject knowledge. Can I have the next? I started dwelling into this area in 2012 when I was asked by Indian Journal of Medical Microbiology to give me a guest editorial as to development of antibiotic resistance and its audit in our country, how to develop an antibiotic policy. And this was the time that we were just emerging out of the fiasco of NDM1. And this is how we wanted to get into this kind of an activity. And not many takers were over there, but gradually and gradually, this is almost 2022, and we are still talking of making guidelines, making a policy. Next, making a policy. And then we try to get into as to what is the educational status. You can see the stalwarts Sanjeev Singh and Asmita Charani as the authors in this, along with the British Society of Antimicrobial Chemotherapy that had partnered in this kind of a study, where it was found that what has happened in the education and training for AMSP programs in the Indian hospitals. And it was not really very shocking, but we are only reiterating this for the leaders to know and the politicians to know who support our systems, that there is no structured provision of education and training for AMS currently that exists in India. Stakeholder engagement is essential to the sustainable design and implementation of bespoken education and training for hospital AMS in India. So I'm sure most of you have realized that, and we need to get into this kind of education and training, which is not actually very resource intensive, but human resources intensive. Next. And then again, we have another stalwart, that's Anita Kotwani, who has been working on antibiotic prescriptions and doing the exit interviews for a very long time. And this you can see is around in 2010, when we were trying to work on the human behavior as to antibiotic use in the community, what factors influence primary care physicians to prescribe antibiotics in Delhi or in India. So it was the diagnostic uncertainty, perceived demand and expectation from the patients, practice sustainability and financial considerations that were driving the prescriptions for antibiotics. And this was primarily for a private practitioner or in the private hospitals, whereas the public sector doctors would say that we are overstocked and near expiry drugs are lying with us, and we are lack of time. We are the factors that promoted antibiotic overuse. So this is what is called as the behavior change, and this is what happens on the ground. And the physician who is in the private practice says that if I do not prescribe, the another physician across the road will prescribe, and I will lose the patient, because patient pressure is also over there as far as the expectations. They want to get well very quickly. Next. So these are the, and this was the community-based surveillance that was done with the help of WHO project. And these findings came in the bulletin for WHO. Next. And you will be surprised to see, not exactly surprised, as far back as 2003, you could see the resistance in community to injectables. Like amikacin, you could see the percentage resistance of around 12%. And look at the cephalosporin status, half of them were resistant. And you could see around 20 to 30% prescriptions having antibiotics in 2003 or 2004. And still further, now we are seeing that cephalosporins have gone with a resistance in Klebsiella and Acinetobacter around 80%, and quinolones have become almost redundant and not usable in Salmonella, which most of us know. Next. Next. So is education of human and animal health professionals about antimicrobial resistance and stewardship educate during their pre-service training? Again, we come back to training, and we wanted to see very recently that was published in IJMM in just 2021. And this is what we found, that is the education. We again want to talk about One Health. And if it is One Health, what is the status of training of the healthcare professionals for AMSP or the monitoring of antibiotic use. Next. And it was found to be really lacking as far as the textbook teachings are concerned. Next, please. As to how many of them have the chapters in that, which was very, very dismally low. And we also, as association, has recommended modifications of MD microbiology curriculum to MD clinical microbiology as a specialty of medicine under consideration of MCI and Niti Aayog. And we have told them that time has come to move on, and we need to take on to the clinical aspect of medical microbiology and have the responsibility towards the community. Next. Next. So the mother of all confusions in ID practice, go on keying it. You can see that we have unexplained fevers around 40%. And clinically defined infections are only 17%. And as microbiologists, we can only provide diagnosis to around less than half of the infections. So that is where the crux of the problem remains, and inappropriate use of antibiotics happen. Next. So why antibiotic stewardship? Because we have reached the dead end. Next. Because in another 5 or 10 years, it may not matter if you have an antibiotic. So rational antibiotic usage necessity is there, although it is not a new concept, but it needs enormous efforts. We need implementation in letter and spirit, because we have reached a dead end. We have nowhere to go. Next. You can skip this, go ahead. So rational antibiotic therapy as an antibiotic stewardship. The clinical team, as we know, has a narrow window of therapeutic opportunity to get the right drug to the right person at the right time. So cost of treatment failure, no physician would afford. So these are the mantras for their treatment, and this can be provided with antibiotic stewardship. Next. If you look at this slide borrowed from Dr. Balaji, and you can see that India is in the top in 30 most common lineages of resistance, particularly in Klebsiella pneumoniae. And if you see that ST231 is the one, keep on pressing it, you can see that this is the one which is actually ailing us, particularly in Klebsiella pneumoniae, and India is in the top position in this. High rate of AMR and or virulence, what we are talking about is in Indian scenario with ST231. If you look at the global studies, you can see that 99 countries are having the KP genome, and carbapenem non-susceptibility is 70%. Porin loss is 37%. This is a very huge figure. Next. This is a very huge figure. So what do we do in as an antibiotic stewardship? So we started in 2012 actually to get into the antibiotic policy. Next. So we tried to get into the literature as to what is most feasible in our conditions to do. And this was the Timothy's reference of 2007, with which we started to build on our antibiotic policy and AMSP. Next. So we tried to simplify this and convert from paper to patient bedside document. Next. Next. Just keep on pressing this. So this is the key stakeholders are the clinicians besides the microbiologists and the administrators. So we have an infection control committee which needs to be involved as stakeholders. Next. So keep on pressing all the keys so that, because the roadmap to antibiotic stewardship, a summary is you need a team as opinion builders in this as a speaker for a meeting, and try to convince people that you need these kind of documents. You need to begin with the microbiology data, which most of our previous speakers has talked about, and have a hospital rollout, develop a protocol which can be used in your own conditions with your own data. Next. And step 1 is how to compile the local hospital data, which should have ICU and wards data separately. You should have the percentage distribution of bugs, as well as the susceptibility pattern to the antibiotics. Next. Next, please. And put the data in the given template that will have the site, the causative pathogen, and you must have at least 12 months data and educate number of samples. Capture the pathogens contributing to 80 to 90% of infections and the susceptibility to antimicrobials from the highest to the lowest. Next, maybe the top 5, which I will show in the next one. Next, keep on pressing it. So if you have a user-friendly kit that we talk of, and this is one of the ways of doing this, that you have your own data separately of ward and ICU. And this toolkit should contain 5 most common pathogens and most antibiotics in the decreasing order of sensitivity, and common validity period. If you see that this is the common validity period that you can give at least 1 year, that you can have the most common pathogens over here with prevalence and the most sensitive antibiotics on this site. Next. Next. So if this is an example, these are the bugs in your hospital from bloodstream infections in the ICU. Press again and take the top 5 organisms. Go ahead. Yeah, if you can take these 5 top organisms causing the infection, and this is the sensitivity of these 5 organisms, put in this template. Next. And this is what is already ready. Half of your antibiogram is over here. You know the 5 top organisms. You need now the sensitivity in the decreasing order. Next. And now you can make similar kind of the templates for BSI, for ward separately, ICU, UTI, SSTI, pneumonia, or even intra-abdominal infections, and you can add as per your requirement. Go ahead. And then you also need to risk stratify the patients. Next. This is defining the patient type when you are do the risk stratification. So you have to have, say, patients of the mild infections, the moderate infections, or the severe infections. This is usually the community acquired. These are the hospital acquired infections, and these are the nosocomial. This is nosocomial infections that you are trying to treat. And these now, after identifying the groups of the patients, you need to do the risk stratification of each patient type, who is likely to behave in which manner. Next. And the risk stratification is based on 3 factors: the contact with the healthcare system, prior antibiotic usage, and the patient characteristics. Next. So you can see this is the type 1. Healthcare contact, no. Procedures, no. No antibiotic in the last 90 days. Patient characteristics, young, no comorbid conditions, susceptible to common narrow spectrum antibiotics. When it is a hospital based, as it is, so has had a contact, procedures have been done on this patient, has been in a facility the last 90 days and has had an antibiotic, is elderly, comorbid conditions, more likely to have ESBLs. Though we have, this is a slightly older slide, we have moved on to NDMs when we are talking of ESBL scenario. And this type 3 again has gone on to OXA48 and the kind of things like PBP3 in E. coli, where we have qualified in type 3. Next. And this is how finally your antibiogram gets prepared. You have the organisms, you have the sensitivities, then you have classified the patient types, type 1, type 2, and type 3 in your facility as you get them. Next. So keep on. Now there's an expansion of the concept. That is, we would talk of antibiotic stewardship, but now as we think that probably we should get into antimicrobial stewardship, primarily because of the fungal infections and the usage of antifungals. And we need to start now so that the antifungals don't go the antibiotic way. Next. And we have a problem at our hands when we are talking of fungal infections, and we are up against a new devil, and these are the invasive infections that we are seeing in most of the ICUs. Next. Keep on pressing it. You can see that the type 4 gets added over here. Next. Type 4 gets added over here, and you need to have the fungi. Next. So you need to have an antifungal, treatment as it is. While we are talking of type 2, there's no role of antifungal agents, but the moment we go on to nosocomial infections, you can see the prophylaxis for fungal infections in very selected cases as above is a possibility. Next. And patients have a risk, go ahead. So pan-drug resistant and fungal resistant infections are over there. So next, so you have type 4 as it is, and you need to include these in your document, and the criteria for that is very well laid. If the patient has been on TPN or hemodialysis, immunodeficient, major abdominal surgery, multilocal candida colonization, and diabetes, they are very high risk, and in type 3 they should be having antifungals on them. Next. And finally, this is the kind of antibiogram. Finally, you have, along with type 4, where you have the antifungal also prescribed as far as your facility is concerned. Next. So the final desired outcome is an antibiogram that should give you all these areas covered for your facility. That is the first requirement when you get into a MSP program. Next. And when we talk of the antibiotic stewardship driver diagram, I'm sure in this workshop you must have already seen this slide, and we have to take on the primary drivers and the secondary drivers, and the appropriate initiation of antibiotic is the one that is of utmost significance because of the mortality that could be more than half, 50%. So the appropriate administration involvement is important, and the de-escalation is supposed to be part of it. Next. So antibiotic stewardship, as ITSA or other societies tell us, is the coordinated interventions designed to improve and measure the appropriate use of agents by promoting the selection of optimal antibiotic drug regimen, including dosing, duration of therapy, and route of administration, which is very essential. Next. And core elements of antibiotic stewardship program is the leadership commitment. It has to come from top. And then there has to be an accountability by way of usage of very expensive medicines that we are trying to give, antimicrobials, and drug expertise is part of a necessity. Action to improve use is to be very, very careful in giving a targeted therapy as quickly as possible. You need to track the antibiotic usage and then report it whenever you find a deviation. And if all this is required, needs to be along with to be introduced in the education program at whichever center that we are talking about. So these are very core elements which can make a lot of difference when we are talking of implementing ASP. Next. If you look at the need of the hour, see the cholesterol sensitivity has gone down in blood isolates. Next. And similarly, if you look at the respiratory isolates, again, Klebsiella pneumoniae and Pseudomonas are showing the resistance to cholesterol. Next. And what have we done? The SGRH experience that we are talking about, in the green, you can see what we have been able to do. And this is what we read in, we are trying to actually struggling to achieve. So services covered have been the indoor patients and the non-ICU areas. What has worked and what has not worked, I will share with you. ASP will have a lot of variability between different hospitals, and that's how each hospital is unique in itself. Next. So leadership commitment, that's what we have got. We have got the human resources, we have the financial commitment, the IT resources, which is very intensive when we talk of AMSP, and it supports and efforts to improve and monitor antibiotic use. As I said, budgetary provisions, luckily we have got and supported by ICMR also. We have an information technology and EMR to collect the AMR and ASP data so that we can monitor as to what we are doing, while we have a very active hospital infection control committee. Drug and therapeutic committee also is there, which is a traditional in all hospitals. Next. So these are the areas that we have tried to address. Only thing is that the ID physicians is a rare variety in our country till clinical microbiologists start taking over. So there is a lack of ID physicians and a clinical pharmacist, but we have just acquired a clinical pharmacist who is now on our panel. Who else can lead if we do not think of a ID physician? So single person leadership can be very demanding even if you have just one ID physician. So you have financial compensations for the ID physician if at all you get one, and a full-time hospitalist or a part-time off-site expertise to develop and manage a stewardship program can be very challenging. Next. So antibiotic prescribing, we have been able to monitor the DDDs, the outcome measures we have been able to find out as to what is going on, including prescription auditing, the resistance pattern, and the cost of treatment. Protocols have been there, the policies have been there, empirical or presumptive antibiotic therapy and surgical prophylaxis is in place, and surgical prophylaxis we usually call as a hanging fruit, low hanging fruit, which is easily achieved. Next. And this is how we report the antibiogram. Next. We try to have the passive intervention at our hospital in the antimicrobials as a part of antimicrobial stewardship program. Next. In this passive intervention, we did not try to tread on the toes of any physician. So we wanted to just share the antibiotic consumption data. And this was a monthly feedback sheets that were distributed electronically along with a hard copy. And respective units were given their own prescription patterns, and they were compared as a percentile score with their own peers. Next. And this is what the information they were given on a monthly basis, that your unit prescribed so many DDDs, average of all specialties across the hospital prescribed so much. In your own specialty, the peers, they have prescribed so many DDDs, and 3% of units in this hospital prescribe fewer DDDs of antibiotics per 100 bed days in your own peer group. Next. And they were also given a table in the table form as to what you have prescribed by way of the group of antibiotics, DDDs per 100 bed days. And then they would be knowing as to what is the average and what's the average specialties across the hospital. Next. And this is this is the unit in question. These are the peers as to how many DDDs they are prescribing, and these all yellow piles that you see at the background is the whole hospital in the drop of whole hospital as to where do they stand by way of antibiotic consumption. Next. And what we found was that when we gave this passive information to all physicians across the specialties, we found that the average DDDs, the low prescribers continue to prescribe low, whereas high prescribers continue to prescribe high. So this is how the pattern was, and we thought that something is amiss. This was a passive intervention. Next. So next. So they remained low, and we thought, okay, fine, probably either they are not understanding these findings. Let us have an active intervention of understanding from them as what's going on. Next. So this was a persuasive intervention where we, regarding their prescription behavior, we wanted to talk to them, and changes that could have been done to reduce antibiotic use in the respective units. So the primary outcomes were total systemic antimicrobial use in each unit measured, and the statistical analysis was done by the segmented regression analysis. Next. For over a period of 1 year. Next. So this is what we found. Overall qualitative measure of antibiotic consumption. You can see this was the pre-intervention, pretty high at times in the over a period of time, and this was the first 3 months of intervention. And at the end of 6 months intervention, there was a sizable amount of fall as it is. Next. So, but we did not find a statistically significant drop of DDDs after 9 months as it was. And by the time it was a year, the tendency was to go up again. So the sustainability of the program was a challenge. Main barrier was lack of confidence. Even one single case of infection, the whole practices will go back and they would go back to 2 or 3 antibiotics. And then any single case, as I said, of infection would result in reversal of previous practices. So this was a very low confidence of the kind of knowledge that could be that the physicians would have. And this is what was documented. Next was documented in IJMM. Next. So the conclusion is that the antimicrobial use, surveillance and research is still in its infancy. The sooner we are able to accurately measure our antibiotic prescribing and use behavior, the sooner we will have a practical approach to improvement. Rigorous antibiotic policy implementation followed by restrictive interventions and a multimodality approach is the need of our. Next. Thank you very much for your patient hearing.
All right, thank you, Dr. Wattle, for such an exhaustive presentation, and apologies for this delay. Maybe we can take one question or so because it's already very late. So if the Bangladesh team is there, there's a question that for them. Mr. Dostogir and Dr. Haque, are you there? If you could come on video, yes. In fact, can all the speakers come on video for a minute or so? That would really help. Thank you, Dr. Henson. And Nikita, any idea, Mr. Dostogir or Dr. Haque there?
Yes, ma'am. Dr. Haque is here. I've made him the co-host.
Right, good. Yeah. And I think Mr. Dostogir is also there. I saw Dostogir written. That's the one you could make co-host. Yeah, Dr. Haque, are you able to unmute yourself? Otherwise,
yes,
you could.
Yeah, I can hear you. Can you hear me?
Yes, we can hear you.
Yeah, I'm right here.
So, right, great. So, we have a question, which is that you talked about the WHO. I mean, your team talked about the WHO GLASS program, right?
Yes, ma'am.
Yeah. So do you think being a part of that program helps in improving the implementation or the program itself, the AMSP program? Does it really help? And if so, how?
Sorry, I was muted.
Right. Oh, Mr. Dostogir, you're there, right?
Yeah, right.
So my question is, I think Dr. Haque has now got muted. And in fact, the others are. So if you could just unmute Dr. Haque and Mr. Dostogir. Yeah. So I don't know why Dr. Haque is muted again. Anyway, so Mr. Dostogir, my question is that about the WHO GLASS program. Do you think that being a part of that program helps in improving your implementation of the AMSNP program?
Thank you very much. This is really a very good question. But like for last 3 years, I've been working on the EPC implementation, and I haven't seen any activities of the WHO since then. So WHO initiated some work like 5 years ago, but it is not continuing. And actually, I also discussed and asked to many, I work on 14 IPC hospital. That hospital is the leading hospital, tertiary care hospital, and no one knows about that program. So it required to be involved the microbiologist, the nurses, and other people. I actually asked all level of people, all types of people, and they are not aware of this. So I don't know whether it will improve or not, but my understanding and experience will have to use the ASP program from the beginning. And I'm working very closely with the Ministry of Health, so that Ministry of Health are aware and they impose some system, and like they're sending the letters for each hospital to form the committee and other things now. And after that, I'm going to circulate all this information, what we are going to do, like the launching the program to all the departmental head of the hospitals and other physician, nurses, and pharmacists. So now people are aware that we are going to do. Year to COVID actually deleted our activities, but we have disseminated in many areas. And actually WHO, I was not aware about any
update or any progress or any recommendation from them. Thank you.
Right, thank you. Anybody else would like to add on this aspect of the WHO class program?
Ma'am,
yes,
I
Dr. Haque.
Words with my respective supervisor, Mr. Dostogir Harun. So what happened is, although WHO class project was initiated back in 2014, but in context of Bangladesh, just like what Mr. Dostogir said, it's more in papers in Bangladesh than being in practice. So unfortunately, although there has been a ministerial dissemination of this project, and they committed of providing the regular data to the regional center, but unfortunately, due to lack of training activities and other commodities, what happened is they failed, I should say, in a measurable way to disseminate this knowledge or this sense of awareness among the healthcare workers regarding the trajectory of the process. Probably some data is being sent to the regional centers for continuation of the project, but still it should be paved towards a longer way for making it a success, just like what Mr. Dostogir said. Thanks, ma'am.
Right, thank you. Thank you for those inputs. Does anybody else have any experience and would like to share? No, okay. So is the Nepal team there? And I could just take one question for them too, and then we could maybe wind up. It's like 7:20 already. Almost an hour later we are from the scheduled time. Is the Nepal team there? Professor Acharya and Professor Dio, are they there? Because I don't see them. So if in case anyone sees them, let me know.
Nobody of them is there, ma'am.
Okay, thank you. So I think we've had a long session. We've learned a lot, I think, from each of these countries. They're all at various stages of implementing ASP. They each have individual challenges, unique challenges at times. And I was actually curious to ask the Nepal team that, do they have antibiotics available over the counter? And is that a social political issue, or is it more related to education of doctors, or what is it? I mean, we all face it. And we've had, government guidelines and government regulations in place for at least some of our countries. But it would be interesting to know from the participants if they have any further questions. So in case you have any further questions, please share them in the chat box. We will share them with the respective speakers. And in the interest of time, we will close this session for today. And of course, the questions you share, the answers, we will revert to you. That's a promise. So please feel free to share your questions. And once again, thank you so much to each of you speakers and to the organizers for a long session and a wonderful session. I hope it was useful to the participants who have stayed on so long. Just over 100 were there so a short while ago. Thank you once again, and we hope to connect someday soon. Thank you very much.
Thank you.
Thank you.
Thank you.